So I will give the pulse after the three talks, but
sir.
I will start.
We are live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to OrthoTV Online Spineconnect Season 2. To introduce today's speaker and moderator, I hand over to Dr. Shailesh Hadgaonkar.
Thank you, Dr. Neeraj Bijlani, Dr. Ashok Sham, OrthoTV for this wonderful opportunity of connect in lockdown to all of us spine enthusiasts. I thank the Pune Orthopaedic Society for this great initiative of discussions in spine surgery. At the same time, Sancheti Hospital for giving us this wonderful platform. Today's Spineconnect is mainly consists of two debates, and it's not debate, it is the understanding of the pathology. First debate is mainly on osteoporotic spine, as we all practice spine where we have single level, 2 level or 3 level fractures. At times it can be tedious. We don't know whether we should do only vertebroplasty or a short fusion or a long fusion, and we have masters for this session. I would like to introduce Dr. Arvind Bhave sir, who is one of the known figure in osteoporosis. We all know the Bhave needle and great work in osteoporotic fractures. Dr. Bhave is working at Dinanath Mangeshkar Hospital as a senior consultant and head of the unit in Pune. Our next speaker is Dr. Vikas Tandon. Dr. Vikas is practicing as a senior spine surgeon at Indian Spine Injury Center. And he is known for his academic wisdom and his great work in AO spine these days. Our third speaker for the first debate is Dr. Vishal Kundnani. And Dr. Vishal is all we know. I don't think Vishal needs an introduction. He's doing a great job in academic research and spine surgery all over the country. Dr. Vishal is practicing at Bombay Hospital and Lilavati Hospital in Mumbai. We welcome you, Vishal. And this session will be looked after by none other than Dr. HS Chhabra. We all know, I really don't need to give any introduction to Dr. Chhabra, who is one of the stalwart legend in spine surgery in our country, and he is spearheading the Indian Spine Injury Center at a big levels nationally as well as internationally. Dr. Chhabra is the ex-president of Association of Spine Surgeons of India, and he will be the academic chair for today's program. We welcome you, sir, for today's webinar, and you giving us time is indeed a great pleasure for us. We have the man who is the most confused in this debate, is none other than Dr. Abhay Nene. Again, this evening is full of stalwarts and faculty who have done great research. Dr. Nene is in spine surgery for more than 20 years, and we all know that anybody but not Dr. Nene will be confused. But we will see in his practice of multiple hospitals, multiple corporates, multiple government and corporation hospital where he practices extensively, trains fellows academically, why he's confused and what all things we would like to learn from Dr. Nene. So he'll be a man who is confused with osteoporotic fractures, and that's where we begin our first debate. Our second debate is mainly on degenerative lumbar spine, listhesis and stenosis, where again, as we always talk about standard posterior surgery, decom, stab, interbody and correction, but there are which is again a gold standard what we always think of, as that is our routine practice, and we have seen great results with that. And we have a great stalwart for this, Dr. Gautam Zaveri, who will be talking about his experiences on posterior surgery in lumbar spine. At the same time, Dr. Vishal Kundnani will be sharing his thoughts on posterior fusion in lumbar, multi-level lumbar problems with stenosis and listhesis. At the same time, something which is going new, and a lot of people are looking at the West, which has been started by, pioneered and started by Dr. Jhala sir from Ahmedabad. I really don't need to give any introduction to the minimally invasive surgeon, one of the greatest faculty we have today, Dr. Amit Jhala from Ahmedabad, with his great credentials, academic and fellow teaching. We all will be looking forward for a great debate today, and I really thank all the speakers, faculty for giving time today for this, and of course you all viewers. We will definitely answer whatever possible questions you send in, and we have all the numbers shared. I would like to start today's session from the first talk, and that from Dr. Abhay Nene. Over to you, Dr. Nene.
So it is a clear case of too much information and too much knowledge. And that has led to this gross confusion, especially in this topic of osteoporosis. And I'm going to open with a very, very simple case, a very straightforward case. This guy with an osteoporotic fracture, active farmer. And all of you would agree that, at the end of 6, 7 weeks, 8 weeks, if he's still painful, we would want to do a vertebroplasty here, is it not? I think all the faculty would agree with this. And that's the sixer or the winning shot that Dr. Bhave is going to sell to us in the debate that ensues. And we followed Dr. Bhave's, dictum, and we did the vertebroplasty with a great result, only to get clean bowled at few more weeks after the vertebroplasty. So I'm wondering here that a case that's ideal for vertebroplasty, a well-done vertebroplasty, has led to a good result with an utter failure at the end. I don't understand. I did what the textbooks asked me to do. I did it right. And still I'm clean bowled at the end of the procedure. And I'm not the only one. There are more and more cases. Another very well done, or I would say good result of a vertebroplasty done in the right indication also turns out coppers at the end of 3 or 4 months. And I think we all are confused here. It's not just me, because we are following the protocol, and it seems like vertebroplasty is failing. And I'd really want to hear from Dr. Bhave how to address this issue. And does he not have these problems with vertebroplasty? And why is he still hard selling it to us so much? So then we say that the winning shot will really come from the striker, the strike man, the hit man from Delhi, Dr. Tandon, who says that, you know what, just fix short along with your vertebroplasties, that you'll get a good result. And that's what we did here. We learned from our mistakes. After burning our fingers, we put in screws and fix short, and only to find that the implant goes for a walk pretty soon. And, you sit dejected there because now the failure is, your hands are bloody now because the failure is on your name. Again, we did everything right. We got the axial correction. We got the axis right. We did a short segment fusion, but we still had an implant walk out in this situation. So I'm again confused as to, what should we follow to try to be over conservative. The senior faculty, Dr. Vishal Kundani, will say that, I know how to dunk the game. I know how to put the ball in the basket. And I will suggest that you do a long fusion. So 3 up, 3 down, maybe, only to be blocked by the big blocker, which is the osteoporosis. And you see what happens in this case where we had done a long fusion. The fusion stays well. There's no implant walking out, but the spine around it is collapsing. And this kind of a collapse is again rife, and it's not a new phenomenon. Again, there are multiple cases where your implants stay back. If you do a long fusion, the implants don't go for a walk, but the spine can't handle that kind of a fusion. And this entire sarcopenic osteoporotic spine tends to break down. And I rest my case. We are all absolutely, incredibly, extraordinarily confused about how to handle such a simple problem of an osteoporotic fracture, which is, bread and butter for all of us. Shailu, I don't know if you have the answers. Dr. Chhabra, I don't know if you have the answers, but we certainly want to hear from the masters and how they sell their goods to us.
Thanks, Dr. Nene, for this wonderful confusion, which is, we really don't know what to do and how to deal with it. I would like to ask Chhabra sir, any interesting case which you come across in recent time about osteoporotic fracture?
Yeah, see, one thing is clear, that this very common problem, right, which very often we don't even suspect on clinical symptoms because the patient doesn't have any, and you diagnose on a chest x-ray that he had some osteoporotic collapse way before. But it can present with a myriad of cases and can surprise you, as Abhay said, n number of times, right? So we have had cases who had a fall. Recently, we had a case who had a fall around 9 months ago, was having pain initially, then the pain subsided, and gradually over the last 14 days, the patient gradually started losing power. didn't have any pain whatsoever. And when came to us, had also the bowel and bladder involvement and significant weakness in the legs. And when we evaluated, we could clearly see that the patient had an osteoporotic compression fracture, which had gradually led to pseudoarthrosis and the neurological deficit. So the key is, fine, Abhay has very well illustrated the confusion, but we can't play God. We are human beings. We can't assure that we will have 100% success rate, but we should be able to, with the evidence and experience base, we should be able to decide what would be the best management for a particular patient and then leave the rest to God. So I'm very sure that with our 3 stalwarts talking, at the end of that, we will be in a better state to understand which patient needs to be managed which way. But I would also want to mention to our young colleagues, don't be under the impression, because they all talk about surgery, that surgery is the only management for osteoporotic compression fractures. Most of them, the vast majority, can be managed conservatively. And whenever you manage the fracture, treat the underlying cause along with it, that is osteoporosis. Because if you don't, then of course the patient will most likely either come back to you or go to another colleague. So that, with that, I think, Abhay, a very well illustrated confusion. I would look forward to the debates which are going to take place.
Yeah. Before we start thank you, sir. Thank you for your kind words. Before we start the debates, I would like Dr. Jhala, because a lot of orthopedic surgeons are watching this webinar and a lot of fellows. What is your take when the patient comes to the hospital casualty or your clinic with osteoporotic fracture? What all investigations you normally ask for when you see these patients?
I think this is a very, very important question, because whenever the patient comes with an osteoporosis, either can have a fall history or a jog, or even without that, the patient will come with just a fracture and a back pain. The first and the foremost thing that I would like the youngsters to, because they usually pounce upon that this is a fracture and we need to do something. But the most important thing is to find out whether it is really an osteoporotic fracture or not. I think that is the key before we embark upon whether it's an osteoporotic fracture. So the investigation should not be only for the fracture itself, but it should be to find out whether there is any other cause for a pathological fracture. So you have to treat it as a pathological fracture, whether there is a primary bone metastasis, or there is a bone metastasis, or there is a primary multiple myeloma, which is one of the most common things which can mimic the osteoporotic fracture. Or sometimes we have seen the infection. So you should have the array of investigations which should have all these things in mind, like lab investigations for all these things, as well as the MRI and the X-rays. So this is what I would say before embarking upon to say that this is an osteoporotic fracture. I think this is a very good, very important message I would like to give.
Thank you, sir. You rightly said. We completely agree that you have to take it as wholeheartedly. Understand, go for a detailed clinical evaluation, understand the pathology, understand the history, understand the nature of fall, or there may not be any fall. All these things are important, and then relevant investigations before we consider treating this. So now I think it's a time for us to go for the debates, and I invite the opening batsman, Dr. Arvind Bhave, today for start of the show. Over to you, Dr. Bhave, sir. Sir, you are muted. Sir, you are muted. Dr. Bhave, you are muted, yeah.
Thank you very much, Shailesh. And good evening to all the stalwarts for nice introduction of this topic. And most of the things have already been said by Dr. Jhala and our president, Dr. Chhabra. So with this basic introduction, I will start my presentation, which I am supposed to talk on vertebroplasty. And this is a ever increasing challenge. As you know, osteoporosis is a big problem and is an enigma. So rising age, am I able to share this?
No, sir, not yet, not yet.
Okay, 1 minute. Share screen, yeah. Is it okay?
Yes.
Yeah. So
You'll have to enlarge, sir, if you can.
yeah.
Yeah.
So as everybody knows, osteoporosis and osteoporotic fractures is a ever increasing challenge to the medical community. And then there is a lot of research, lot of things which are coming up and which are in process, in pipeline, which we will be having in years to come. So rising age is the biggest problem today we face all over the world. And hence rising age means more degenerative disease, more osteoporosis, and maybe in future we are going to see this type of people who had suffered so many times because of osteoporotic fractures. For example, this is a published paper by Lieberman in Spine 2001. This is first picture is apparently a benign looking fracture as seen by Dr. Jhala in casualty. Apparently it is a simple, stable, low velocity fracture with 16 degrees kyphosis here. This X-ray taken on 31st August 2000. But if you keep a close watch on this patient, then next X-ray in almost 3 to 4 days after this, you can see there is a further collapse. And that is where the things start worsening actually. So we have to be very alert at this particular stage. Even if we feel that it is stable, nothing to worry, go home, sleep, use brace, take this calcium, vitamin and this anti-osteoporotic medicine and enjoy. But that is not into it. You have to be cautious. And this has already been documented in Spine Journal by Professor Lieberman. So these are the fractures which look benign, but they can create a problem. And hence, we are faced today with the challenges, whether to go anteriorly, posteriorly, big segment, long segment, short segment, minimally invasive or whatnot. So whoever is a surgeon, whatever comes to his mind can be a good idea. But we have to make it a tailor-made solution for a particular patient we are talking about. And hence, these debates are going to continue in future. Let us but at least things are clear that what are the objectives in vertebral compression fracture treatments. First is early diagnosis, early therapy for optimal outcomes, restoration of anatomy if possible, and special care for geriatric age group patients, because these have got multiple medical problems and we have to take care of this and think of it while treating any fracture. So early intervention may reduce the duration of acute pain, which will reduce the use of analgesics, duration of immobilization, because more you immobilize a patient, more they become osteopenic, and then chances of lung and DVT and other urinary infections also increase. And this can cause chronic back pain. Further collapse can occur because increasing of osteoporosis leads to kyphotic deformity, and then compromise of chest cavity, and finally about 22% increased mortality if we just neglect these fractures. So today's topic, my topic is on the benefits of vertebroplasty. The pain relief is quick and almost complete, and they have improved mobility. They are able to stand and walk within first 24 hours. And hence almost 85 to 90% of patients have got dramatic pain relief in first 72 hours post vertebroplasty. We are talking of benign osteoporotic fractures. So let us see a case. This was a 74 years old female patient, diabetic, hypertensive, angina, urinary infection, everything. She suffered a spine fracture while traveling in a bus and hence treated conservatively with rest and medication. I will present a serial X-rays of this lady, but with bed rest for 3 months, she didn't improve. So let us see the X-rays. This was her initial X-ray, apparently looking benign, and hence everybody would agree that she just requires a conservative treatment. But this is the next follow-up because her pain increased. You can see the collapse here. This further follow-up, 1 month duration, pain doesn't subside, July 23, and now in September, you can see clear-cut development of a cavity inside. So she is developing now Kumel's lesion, kyphotic deformity. See what has happened with conservative treatment from April to September. And at this point, she came to us with intractable pain, so many analgesics for the last 3 to 4 months without much relief. And at this point, we offered her vertebroplasty because she was having so many medical problems. And this is a picture post vertebroplasty. You can see Kumel's lesion nicely filled up, AP view, lateral view, and a dynamic load bearing view. This is immediate post-operative first week. So this was the situation. And unfortunately, this patient disappeared. So I was very worried. These relatives were, because patient was outside, every month they used to get the x-rays. Even the local doctor used to treat there, saying everything is good. And this was the situation which happened. And after this lady disappeared. And suddenly she appeared in February in my OPD with lot of pedas, boxes, sweets, mithai, everything. And then I said, where you had gone? I was worried about you. And took her x-ray to find out this was her picture, February 2004. And she just laughed quietly and said, doctor, this surgery was so nice that I could do my Char Dham Yatra. And this is a prasad for you. So you can see hardly any scar seen, everything done under local anesthesia. And this lady who was bedridden, could not even get out of her bed, has done her Char Dham Yatra. And this is her picture almost 6 months post procedure. And this is her 5 years follow-up. You can see same picture as if immediate post-op, no collapse, no adjacent fracture. So I particularly feel that avascular necrosis or Kumel's disease is a classical indication for vertebroplasty, where patient is demanding something from you and you are seeing patient worsening in front of you during the follow-ups. And because of this age, they are having multiple medical comorbidities. And hence this becomes minimally invasive modality, done everything under local anesthesia, patient awake, and that is the result you are likely to get. So when we think about talking of low energy, non-fusion, minimally invasive technique, we have a spectrum of things to offer to the patient. First principle is where you don't restore the vertebral body, you are just offering surgical treatment for pain relief. And that is where we are just injecting the cement to do vertebroplasty. Next is where we are trying to correct the deformity, where the principle is to create a void either by mechanical pressure or by hydrostatic pressure. In mechanical, you have various varieties available, and in hydrostatic pressure, you have famous kyphoplasty with kyphox X balloon or balloon kyphoplasty. And third thing, where we don't create a void, we use hydrostatic pressure, and that is termed with an implant inside, and that is termed as a vesselplasty. And this is already published in Journal of Musculoskeletal Research in 2008. This is where I came into the picture of research of this vesselplasty, and we were in initial first 5 years of this. So let us see, this is a vesselplasty. You can see 76 years old female, fracture L1. You can see so much of compression, 6 weeks bed rest. Her X-ray showing so much of collapse, adjacent vertebral heights are 2.51, 2.71, and this is collapsed to only 0.92. And this is immediately on table Siam picture, where you can see nice gain in the height, nice correction, and this is 6 weeks follow-up, and patient is doing well. It is now almost 3 to 4 years post-op. There is no collapse, and that is a beautiful result what you get. Everything done under local anesthesia and under Siam control. So that is the thing you can get. And I think even if he or she is your relative, everybody would like to have this type of sort of result at the end of the procedure. There is another 82 years old male, 2 months history of fall, treated conservatively. And when he came to us, this was his picture, bedridden and severe pain, even could not get up out of his bed. And this was a critical issue, what Abhay had described in his previous thing. So at this time, we were puzzled what is to be done, because probably he's developing instability and also cord compression. but he was totally unfit for general anesthesia. And hence we tried to try our luck. So under local anesthesia again, you can see Siam picture, implant inserted, implant getting inflated with the cement inside, hydrostatic pressure, this much correction. This is at the end of the procedure, AP view, and this is 2 months follow-up. And now it is more than 2.5 years and there is no collapse. So impending neurodeficit that has also been treated with this without any major GA, major surgical scar or major implant inside the patient's body. So this is a result we are likely to get if your selection is good. This is another lady, 70 years old female, angioplasty done 3 weeks ago with double stents, and hence she was on double anticoagulants, diabetic, uncontrolled, and she had a fail immediately after angioplasty in hospital itself and suffered from this fracture. But with 3 weeks conservative management, pain didn't subside. So this was her MRI picture. You can see she is developing a cavity with a burst fracture. This is a CT scan axial view, and this is a MRI scan axial view, where you are convinced that she requires something to be done, but just 3 weeks post angioplasty, and hence cardiologists and anesthetists were resistant for any type of general anesthetic or any major surgical procedure. Otherwise, as routine, we could have advised her corpectomy and anteroposterior fusion or minimally invasive percutaneous pedicular fixation with anterior column reconstruction. So because it was contraindicated for any GA, I used this modality, tried mechanical decompression here, mechanical lifting up of the end plate, and then passed my vessel. This was immediately after, at the end of the procedure, Siam picture. You can see the implant nicely fitting in the anterior column. So that is a weight bearing column at D12 level. And this is her 1 year follow-up. You can see biomechanics nicely achieved, no collapse, and patient is moving on her own with her only cardiology and medicine drugs. So this is a result you are likely to get if you have proper selection of the cases and treated at a proper way. Where else you can use vertebroplasty or cement augmentation? This is a 82 years old lady, household fall 3 weeks, suffering from multiple spinal fractures. Now what to do? So we did simultaneously multi-level vertebroplasties. You can see the Siam pictures, needles introduced, cement going inside. At the end of the procedure, lateral view, AP view, and this is 6 months follow-up. Patient was immediately mobilized on 3rd day with a brace, and till now she is doing well. So this is so far as multi-level augmentation is concerned. This is another interesting case. This is a 115 kg old lady, very short lady, and suffered a fracture L2. This was in September 2003. She was highly diabetic, hypothyroid, so all sorts of things, medical problems you can imagine she had this. But that time we were doing only vertebroplasties. So I did vertebroplasty for her and put her on teriparatide. This is 2 years follow-up for her. So far as she is doing well, 2 years post vertebroplasty L2. And then she was happy, I was happy, everything was going on very well. And then again in January 2019, she had a fresh fall. And now she had developed a new fracture 1 level above. But she said, I am coming to you because I am very, she was convinced the role of cement augmentation in her previous experience. So she demanded this time, no, this time you do the same thing. I said, madam, you have gone 4 years down the line, your weight is still 115, 20 kgs. You have not reduced even a single kg of weight. You are high surgical risk, you are hypothyroid, diabetic, everything, all routine things. I talked to her, but she convinced me to do this. So this time I thought again we'll try vesselplasty. So vesselplasty was done under local anesthesia. This is a implant inside, guide wire removed. Implant is getting filled with the cement, opening up the implant. You can see this is lifting of the end plate, you can see, and this is the final picture. This is my previous vertebroplasty 2013. This is 2019. Final picture at the end of my procedure. Everything done under local anesthesia for this lady. And this time I had to step up and given her denosumab. First dose was given in January 19 at the time of discharge. This was her post-operative X-ray after 1 month. And this is after second dose. That time we have taken this second follow-up X-ray where you can see there is nice intermingling of the cementing material with the bone tissue. There is no collapse. Everything is maintained well. And that is the result you get if you are giving proper medication, good follow-up. And remember, one has to be very advanced, or you have to use advanced drugs, because only calcium and vitamin D doesn't help in these patients, because this is how you might come out with good results. This is very interesting case. This was an 84-year-old man from Panvel. He had trivial fall 6 months back, somewhere in 2014 September, and suffered fracture D12. Treated conservatively there. Again, he tried something, had fall, suffered from fracture L2 in December 2014. And then, as usual, he was treated with bed rest and so many things. But when he was brought to us, he was bedridden now almost for 6 months. He had developed urinary tract infection and worsening of back pains, but his neurology was intact. So at this particular point, I intervened, and this is his MRI showing fresh fracture at D10, old fracture at D12, and older fracture at L2. So these are the 3 fractures. And here you are not sure whether the posterior cortex is intact or not. So what to do? Because operating all so many levels and plus long fixation I would have fixed almost all his spine. So again, we tried to act smart, and these are the axial views where this posterior cortex probably is communicating with the spinal canal. So what we did is, under local anesthesia, we could do postural reduction. So plan we fixed on the table itself for the fracture D12, which was 6 months old, which remained collapsed, didn't open. So, but patient was having tenderness. So decided to do vertebroplasty. The L2 fracture was just 2 months old. It opened little bit, and hence we tried our luck with kyphoplasty using balloon Medtronics. So kyphoplasty was done for L2. And for this fresh fracture, where the integrity of posterior wall was not clear, and it was a cord level. So for that, I had done vesselplasty under local anesthesia. So in single sitting, all these 3 procedures, you can see vessel put in the anterior column. Okay, this is a vessel kept in the anterior column. For the middle level, where it didn't open at all, here just for the pain did vertebroplasty. And for the L2, which was relatively an older fracture, about 8 weeks, then was treated by kyphoplasty. So all the 3 modalities of augmentation were done in one single patient, one single sitting, because he was 84 years old. And this is his picture 6 months post-operative. You can see all the 3 vertebrae are maintaining well, AP and lateral views. And this was clinically, immediately the patient didn't get up for last 6 months. He was able to sit very next day, made him stand very next day of the procedure. This was independently walking, and you can see he's walking without support. So all the 3 modalities of augmentation done in the same patient. This is a 2 years follow-up, no new fracture and no adjacent level fracture. But sometimes situations are not in our favor, where you can have instability also. So this is a lady having fall leading to multiple osteoporotic fractures with an instability here. And here we choose to have combination of treatment, where we did vertebroplasty with support posterior fixation and isolated vertebroplasty for the lower down fracture, because it was also tender clinically. And this is our 2 years post-op X-ray, where you can see implants are in position, vertebroplasty, cement, everything is fine, no adjacent fracture. So this is 2 years follow. And this is still a difficult situation. This patient was already suffering from pulmonary tuberculosis, and she has completed 8 weeks of 4-drug regimen. and had household fall and has come to us with totally bedridden condition. Now you can see she has a fracture here. This is a doubtful. You don't know what you are able to do and how you are going to get out of it. This is a situation on the CT where we tried all possible ways. So we did vertebroplasty through one pedicle, fixed it, and also used augmented screws. This is a round table picture. This is at the end of the procedure, and she is doing fine. She has completed her 14 months anti-tubercular treatment and walking well now. So we have to choose whether you have to use minimally invasive surgical options or maximally invasive surgical options, or do antero-posterior thing, depending on the fitness of your patients and demands of the patients, and what is the thing you are going to try and what is the end result you are able to see. So various choices are with us. So take home message from my side, from my experience, vertebral fractures, they are notorious for progressive collapse. So you have to be very alert at every follow-up, have frequent follow-up, and convince the patient to have frequent follow-ups. Implant loosening is a big challenge for us. So that is why we are using cannulated screws with cement augmentation. Newer technologies will prevail, and we will have better technologies in future than what we are having today. And there is no replacement for medical treatment. So whatever surgical procedure you have to do, you have to be very, very advanced and use all possible medical management to make that fracture heal from your side. So this is to complete. Yeah, last slide I'm talking about. So my logarithm, where we have augmentation only, augmentation with fixation, augmentation with decompression and fixation. So augmentation only when disability is due to pain, but there is no instability and no neurological.
This is the debate we would like to control
okay.
your presentation, because then it will be diluting everything.
Okay, so thank you.
Yeah, thank you for a wonderful presentation and your cases. The scenarios were beautiful and exemplary work. You've shown not only vertebroplasty, but kyphoplasty and vesselplasty, which are all for basically cement augmentation procedure for pain relief and stability. I would like to invite Dr. Vikas Tandon for the next presentation on this debate of osteoporotic vertebral fracture and why Vikas chooses for a shorter fusion. Over to you, Dr. Tandon.
Can you see my screen, please?
Yeah.
Yes.
So thank you. I think it was a fantastic presentation by Dr. Bhave, and very nice cases shown by him, and shown very good results. But as Dr. Abhay Nene has pointed out initially, the things don't go usually that way for everybody. And I think Dr. Bhave, being an expert, he's been fortunate to have such fantastic results with him. As per the literature, I would go by what I would go with the literature. So if you look at the spectrum of what do we do when we are dealing with osteoporotic collapse or osteoporotic fractures, and for the sake of presentation, I'm going to stick to thoracolumbar region only because that is the region which is most commonly involved. So obviously you can do, vertebroplasties, you can do kyphoplasties for certain fractures. You can decide to do short segment fixation, and you can decide to do something like what Vishal is going to speak on, long segment fixation with kyphoplasties, or with the corpectomy, you can do a long fixation. So there is a whole spectrum of this thing, of the management that can be done for these fractures, surgical management. And I'm here to speak basically on short segment fixation. So why short segment fixation and why long segment fixation? We will actually that is a major debate which is there. If we draw a line, what Dr. Bhave has told us. So when a patient comes to you with neurological, there is no neurological involvement. The posterior wall is basically intact, and there is no instability. So these are the classical cases where you can perform things like vertebroplasty, kyphoplasty, vesselloplasty, all these things. But when you have posterior wall involvement, you have instability, you have neurological deficit, then your good friend implants come into picture. And then you have to figure out how you're going to put your implants, whether you want to put your implants posteriorly, anteriorly, are you going to augment it, how much you're going to put implants, small, short segment or a long segment. So this is the debate right now, basically. So there are very clear indications for vertebroplasty and kyphoplasty. The debate is basically on short or long, but I think Vishal is very lucky to have this debate, especially for osteoporotic fractures, where he has a clear advantage being an osteoporotic spine, osteoporotic vertebra. I'm going to make his life a little easier after my presentation. So let me proceed further. So by definition, if we go by definition, a short segment stabilization is when you are fixing one level above and one level below the fracture site with an intermediate screw in the fracture. So that is short segment fixation. That is by definition. And when you do 2 above and 2 below plus minus intermediate screw in the fracture vertebra, that is known as long segment fixation. So this is by definition. There is no change in this. This is the classical definition. Now you can augment, you can put your screws with or without your augmentation with cement. So let's proceed further. So debate is basically short segment versus long segment fixation. Now there is actually advantage and disadvantage of both. When we talk of short segment fixation, you are trying to save segments of motion, and there is obviously less operating time and blood loss, which is very important in these fragile old patients who present with these fractures. Whereas long segment fixation definitely has the advantage of a very good implant and fracture stability, especially in these osteoporotic spines. And obviously you get a better deformity correction and alignment. These are proven facts, and I don't want to set a wrong precedent by saying that short segment fixation is the panacea for all kinds of fracture. There is a subset of fractures which can be treated with short segment fixation, but when we deal with osteoporotic spine, the way to go and the classical teaching has always been a long segment fixation, though I'm speaking on short segment fixation. So Vishal, you'll be happy this way. So I think we need to spend some time on this slide. It's very important for us to understand the morphology of the fracture before we decide upon what kind of fixation or what we are going to do for the fracture per se. So this is a classification of osteoporotic thoracolumbar spine fractures recommended by the German Society of Orthopaedic and Trauma, published in 2018. So just focus on the diagram there. If you look at the first, that is OF1 and OF2. So basically only these are the two which are to be taken care of by kyphoplasties or vertebroplasties. OF1, if you see the X-ray and the CT scan, you will not see anything. Actually, they will be normal. Only the MRI would show the stir image would show that there is hyperintensity. OF2, just an impression of the one end plate of it, and the posterior wall is not involved or very minimally involved. So these are the ones which are to be treated with a kyphoplasty or a vertebroplasty, ideally speaking. OF3 is the one where the end plate is involved and the posterior wall of the vertebra is also involved, almost about 20%. And then you have OF4, which is when both the end plates are involved, when there is a vertebra plana or it's a pincer type of a fracture. And when these progress further, they can lead to OF5, which is a kyphotic deformity. So this is how you have to look at, when you look at your X-ray or MRI, you have to first visualize this particular diagram. This is very important to decide, because OF1 and OF2 will not usually progress further into a bad-looking deformity. Whereas OF3, which is a type of a incomplete burst fracture, these are likely to progress further. They have involvement of posterior wall. So kyphoplasties and vertebroplasties are supposed to be avoided ideally in such scenarios. Let's proceed further. Now, when we deal with fractures, burst fractures in adult patients, in other patients, there have been very great results of short segment posterior fixation. There have been multiple studies which have shown that short segment fixation with an intermediate screw works as good as a long fixation for a burst fracture at the thoracolumbar region. There have been multiple studies. One of them is highlighted. In fact, two of them have been highlighted here. But however, these results were based on the observation of a traumatic fracture in young patient, and they were not osteoporotic population. There is a difference, and we need to understand that difference. We are dealing with an osteoporotic patient where the bone physiology, the biomechanics are totally different when you put in your instrument there. And that is the whole, debate about actually. You cannot, that is why there have been an enormous amount of advancement in the techniques when you are putting screws or instrumenting your osteoporotic spine. There have been advancements, in the implant per se, as to what kind of implants can be used for osteoporotic spine to improve your complications, like pull-out screw or loosening of the implant in the osteoporotic spine. There have been multiple cements that have been, the things have been, invented or discovered, which can be used to augment your screws, which can improve your fixation in the osteoporotic spine. So definitely you are dealing with a different subset of bone, a different kind of bone, which is not normal or a good bone. It's an osteoporotic bone, which needs to be tackled differently. And therefore, when you deal with conditions, when you deal with osteoporotic bone, you need to work on your surgical techniques. You need to work, or you need to adopt some newer implants. So basically, if you talk about the surgical techniques, there are basic principles when you deal with osteoporotic spine. You have to, you have to use a larger diameter screw, which can be used to fix the osteoporotic spine, which it's a good purchase in the pedicle. You need to increase the length of the screw. So all these things will come into it. You can supplement with the anterior fixation. You can use the minor hooks or wires. So all these things would help you improve your surgical technique to fix up in an osteoporotic spine. So there are certain novel surgical techniques which have been developed to improve your osteoporotic fixation, like cortical bone trajectory. You can use bicortical screw technique, which is very commonly used. So you put a longer screw, you try to engage the anterior cortex to get a better purchase of your screw in the osteoporotic spine. And then you have different novel screws which have been developed, like expandable screws, coated screws. But when we are talking about fractures, I would not push in too much about the coated screws, because they take time for incorporation in the bone, and therefore you need immediate stability, for where I would recommend putting cement and putting a screw there so that we can get immediate stability. Cement augmentation is another way of improving your pull-out strength of your implant there. So going further, the techniques have further improved. Recently, people have started using universal clamps when they are doing short segment fixation. They have started using universal clamps to improve their fixation in the osteoporotic spine. They have started putting transdiscal pedicle screws to improve the fixation in osteoporotic spine, and also to reduce the size of the constructs. So this is our normal tendency as surgeons. We always try to reduce our implant and try to get the best out of it. But it is not for all kind of fractures. So that is what I'm going to come to. So if we look at a study which was published in 2020, recent study in Asian Spine Journal, they compared the long versus short segment instrumentation in osteoporosis in thoracolumbar vertebral fractures. And they came up with the conclusion that both treatments showed good clinical and radiological results. However, the bisegmental kyphotic angle was better corrected with the longer fixation and not with short fixation. And there were some mechanical failures with short segment fixation. So there would be some failures. So how to avoid those failures in short segment fixation? And because see, when you do long segment fixation, there is nothing to be worried about. You fix the whole spine. So there is no problem with any surgery done by Vishal. That's why he would come in the last and he will, take the advantage of it. But when you are doing short segment fixation, you have to look precisely what fracture exactly you have to fix in a short way and come out well. I agree, not all fractures can be treated with short segment fixation, and that is what I'm coming to. Again, there was another study which said which again assessed the stability of long segment and the short segment fixation in burst fractures in thoracolumbar junction and osteoporotic bone. This was a finite element analysis, and again the same thing. The long segment fixation was a better fixation according to the finite element analysis, but the results were not too bad for short segment as well. Now, this is again the same study which I was talking about, the recommendations by the German Society. And they said in their recommendations, this was published in 2018, that OF1 and OF2 can be treated with kyphoplasties and vertebroplasties. Ideally, OF3 is the only fracture which can be treated with short segment fixation, because when they saw the results of short segment fixation with OF4 and OF5, there were some mechanical failures like pull out of the screw and loosening of the screw. So if you see a OF3 fracture, which is a fracture or of the upper end plate or one of the end plates with involvement of posterior wall, where neurological deficit is there, you can attempt a short fixation. You can attempt short fixation in some of the OF4s, provided you are taking all precautions to improve your fixation in, or dealing with an osteoporotic spine. You are augmenting your screws properly, so probably you can venture there. But as of now, as per the literature that we have now at this point of time, it is only favoring OF3s which can be treated with short segment fixation, and some of the OF4s with good augmentation. So they recommended this. Now, just coming short and quick to these cases. So usually, let me make a small disclosure. I don't myself do too many of these short segment fixations. I follow a middle path regime, which I'm going to show it to you. This is a OF type 4 fracture. It is not 3, but this is not my case. This is for my colleague, and they did a short segment fixation with cement augmentation, a short segment fixation, one above, one down, and one intermediate screw with kyphoplasty. Not too old. They have recently done this, so I do not know the follow-up of this. My colleague's case. Another case of similar variety, lumbar. This is L4 fracture. Again, a OF3 kind of fracture. Especially when you're dealing in lumbar spine, you need to be very cautious about the number of levels that we're involving, because that's a mobile part of our spine, and you need to take, it's important that we have short segment fixation, again treated the similar way. Another D12 fracture treated in the similar way, OF4. Right, now, this is what I usually prefer to do in my practice. I prefer a middle path. Middle path is when I get a fracture like this, which is OF3 or OF4, and you need with or without neurological deficit, and I'm sure I need to put in my implant there. I do a proper augmentation. So if you actually notice this particular X-ray, the post-operative X-ray, and I've also put some CT scan views over there. This is how I augment my screws. I usually put a very long screw, and I try to engage my anterior cortex. So I always try to get a bicortical purchase. And recently what I started doing is I put in cement in between. So basically it's a double sort of augmentation. It's a double augmentation technique wherein you are augmenting your same screw with anterior cortex at the engagement, cement holding in the middle of the shaft of the screw, and the pedicle behind, which is getting engaged with the screw. So basically this is how, and I have been doing this for last so many years. I have never repented. So if you plan so this is basically why I call this middle path, because this doesn't fall into the category of short segment fixation, neither into long segment fixation. But with this, I have never failed. So let me proceed further. This is what I published last year, the same technique, wherein you do a double augmentation with putting a longer screw through the cement and engaging the anterior cortex. And the results have been very, very nice. God has been very forgiving to me with this. Some of the cases where short segment fixation will not work by definition, like this is a case where you see gross instability. You can see the flexion extension MRI, which has been done below that. You see a common side. It's a pincer kind of a fracture, completely burst. And these are not the ones which are to be treated with short segment fixation. And therefore, you need to do something which is long. So you put more screws, you try to get more purchase. In this, I have not augmented, but I have taken anterior cortical, I've done a bicortical purchase and done a kyphoplasty or vertebroplasty in the fractured vertebra. So again, different scenario, vertebra plana with neurological deficit, with little kyphotic deformity there. These are again not other cases which are to be treated conservatively. You might have to do a corpectomy and cement augmentation with longer fixation. Similar case, you get similar anterior big voids. Again, these are not cases which are to be treated with short segment fixation. As per the literature that is available today with us, these are to be treated in a different way with a longer fixation and anterior reconstruction. In this case, I did vertebroplasty because this patient was very fragile and I had to be out quickly. So I did this. But this patient is doing very well. Another case of the similar kinds. So, which is not to be treated conservatively because with the short segment fixation. So basically, to conclude and to give you the right idea, when you have basically when a patient comes to you, you look at the fracture. You try to understand the morphology of the fracture. Ideally, OF3s and some of OF4s are good for short segment stabilization. Augmentation and following the principles of fixation in osteoporotic spine would improve life of your surgery and instrumentation. And please don't forget medical management of osteoporosis. Thank you so much. And with this, I would like to conclude my talk.
Thank you, Vikas, for a wonderful presentation. I know it was a challenging task of a short segment, but you presented it so well. So I'm sure this debate is becoming more interesting. This is a personal experience as well as what we really practice and what is ideal and good for our own practice in osteoporotic spine. One thing I just thought of just checking, you talk about short segment for 1 level fracture, and if it is a 2 level fracture, so maybe 2 above, 1 or 2 below, again becomes a short segment. It's not a longer segment, maybe 4 above or 3, in that context. But you presented it so well, the master blaster from Delhi Capitals, and we are looking forward for the Mumbai Indians superstar Vishal Kundani. Over to you, Vishal, for long fixation.
I think Vikas is smiling and Bhavesh sir has already put his screen off. The debate is already won. And I think Bhavesh sir forgot that he is from an era when TB was also managed surgically. All infections were managed surgically. Unfortunately, we are born in an era where TB, infection, and even osteoporosis is either managed medically or it is managed properly. And I want to tell you about how to manage these patients properly. This one slide before Arvind and Vikas goes away and disappears from the screen, please take home these slides for yourself. We got to innovate new surgical strategies. Vikas has set the ground so straight for me that I just have to read out these 4 pointers. And if you have to take home any one slide from here, this is one slide that everybody must carry home, that surgical management of spinal condition in elderly osteoporotic patients, be it osteoporotic fractures or any other thing, has new strategies. They are laid down, they are written down. There is enough literature, there are enough studies to prove that you have to follow these principles. And the baseline of this is augment the caudal and cephalad vertebrae, plan an incomplete correction of any spinal deformity. And the most important point is that with these poor bone stock, always involve multi-level fixation and sometimes even iliac screws. Just to show you one case scenario where I am sure where there is a split vertical fracture there, like Dr. Vikas rightly highlighted, these are the cases, though there may be multiple options running into your mind. And with the success story of Dr. Bhave's presentation with so many vertebroplasties done in so many different type of patients, you will already start thinking of doing V-plasty, K-plasty and B-plasty. You may also want to think about some short fixations, but the answer to these is not any kind of short fixation because there is obvious instability coming up. And just to disclaim here and make it absolutely clear that this debate is meant to keep Shailesh busy. Shailesh has actually got our evening busy on a weekend. कि चलो एक debate करते हैं, तो debate में क्या करेंगे? Let's highlight Vishal Kundani and Vishal को कैसे highlight करेंगे? तो 2 extra talks ऐसे time pass के लिए रख लेते हैं, ताकि विशाल का talk time पे तब तक you'll have the crowd to come and listen to you. So now we have the right crowd and we have the right point. And let me put to this point: there is no debate at all. Because this debate is not at all about those 95% osteoporotic fractures which get completely better. Plain pseudoarthrosis or Kummel's lesion, actually, it doesn't exist only. My feeling is that these kind of defects which require or which we do well with V-plasty, K-plasty, or for that matter, B-plasty, or for that matter, tendon-masti, all these kind of lesions don't exist. And if they exist, they don't get better with B-plasty or T-masti. They actually are the cases where nothing is required. And as I said, the natural history of osteoporotic fractures is 95% of people don't need anything. They just need time. They need time and patience of the surgeon to not jump on the patient to do something. They just need optical medical management. And all these patients on whom we generally tend to jump upon and do vertebroplasty, they will either unite And if they don't unite, they will end up into either progressive deformity or neurology, where neither short segment works and vertebroplasty is a strict contraindication. And this is something, as I said, you can do whatever you want at whatever stage, whatever you like, whatever kind of plasty you want. But patient doesn't needs it because he's still in the phase of healing. You just have to give patient the time and optimal medical management. That's the key to it. And then there is enough evidence to say that there is no evidence for vertebroplasty or kyphoplasty. In fact, there are papers to compare placebo to vertebroplasty. Even injections for established cumulus lesions with saline have shown amazing results in articles like NEJM and Lancet, where they have proven that these are all sham procedures and probably they are not required. And you are doing something where nature would have done everything for them, and you have liked it and you have did it something. This debate is about some serious topic. And this debate is about cases where there is progressive issues of kyphosis with pseudoarthrosis, where patients are not healing and they are developing deformity. They have developed neurodeficit, where there is a complete failure of posterior tension band, where there is end plate fracture, and that's why they are not going to heal in future. Or there are vertical split fractures where no amount of cement is going to bring back the anterior fragment to hold on the posterior fragment. And if you have any of such fractures, these are the fractures which can not only be caught on day one, but also over the phase of evolution. When the natural history is progressing, you'll actually catch them and know that one of these factors is not going to allow it to heal. And even if it heals, it is going to heal with either significant kyphosis or with neurology. And if the patient has already come to you with kyphosis and neurology, you know that short segment or V-plasty is not the game for it. As I said, if you have to do something in these cases, follow the word of Dr. Vikas Tandon, who has already taken a back foot and said that Vishal is going to make a good deal about it. Yes, I'm making a good deal because there is no B-plasty and no T-plasty that's going to be required for any of such cases. And this list is only growing. I'm sure all the surgeons here will say that the list of contraindications of vertebroplasty has grown bigger than the indications. So in last 10 years, one thing that has become bigger with vertebroplasty is the list of contraindications. And as you follow more and more of your patients, 2 years, 5 years, 7 years, you will see that this list of contraindications is only going to grow bigger, and you're going to see more and more unsatisfied patients as the follow-up increases. And these are just some cases that have come across in my short span of experience, where vertebroplasty has not only failed with complete cement loosening, big lucencies around the cement blocks, cement protruding out, cement going backward, and all these things result into persistent symptoms. It may happen not in initial 3 months, when you will actually want to do multiple number of x-rays for your PowerPoints to show to the people that vertebroplasty or kyphoplasty or short segments work. But it only happens after 5 months, 6 months, 12 months, when they actually start eating upon the bone, creating erosion and loosening of the cement mass. And that's why in all these cases where these serious cases are coming across, vertebroplasty may not be the one that is recommended in these patients. And these lessons we have learned in a very hard way. And we have not kept it to ourselves. We have published it extensively, not once, but thrice. And we have said that if a patient has the osteoporotic fracture with any of these risk factors, wherever you see instability, a big khadda lying out there, which is the established cumulus lesion, or an end plate fracture, or a PLC injury, which is going to require a lot of cement in there, or there is too much kyphosis on dynamic films, you better don't do any kind of local procedure, or a kyphoplasty or V-plasty may give you good results in short term, but in long run, you're going to be repenting and your patient is really going to be strategically in disaster. And in all these patients, if you see risk factors present, you got to follow the biomechanics of spinal fixation. But remember, when it comes to biomechanics of spinal fixation, you really don't have to follow the usual biomechanics where 2 above, 2 below and anterior reconstruction helps. No, it is meant for TB, infections and tumors. In elderly patients, these biomechanics of principles do not work. And if you mess with them, you miss with them. Like in these particular cases, which Vikas highlighted, short segment fusions, Vikas rightly mentioned he has got no follow-up of these short segment cases. And there are enough papers to mention that all these results are only for 1 year, 2 years. And in long run, what do you see is this. We get to see so many of them where you have done V-plasty and you try to do short segments, saving lumbar segments. They will only come back to you to have larger, longer, bigger and disastrous surgeries. And these are the ones who will be in terrible shape in later date. And this happens not only when you do 1 level above below. This can happen when you do 2 level above below. And this can also happen by not only cut out of the implant, but also put out of the implant. And all these things are not so uncommon. They are extremely common. They have happened to us. I'm sure they are happening to everyone else. So either you don't do anything or you do something optimal. And all these optimal strategies now are laid down very clearly that fixation points are lowered in osteoporotic points, and that's why to enhance the fixation strength, you got to follow certain principles or don't do anything, wait for the patient to get medically optimal. So sometimes waiting game is the better game. If you really feel that suboptimal work is to be done, you'd rather wait rather than just getting tempted to do something less, because 50% of your implants will fail in no matter of time. And so all these difficult lessons that we have learned difficultly and in a very, very difficult time with all these patients failing to us, I'll tell you that one, normal biomechanics do not work in these patients of 2 above, 2 below, or 1 above, 1 below short biomechanics. They just don't work in these elderly patients. So the message number 1 is follow the biomechanics, which has to innovate from here. And the strategy to this is do not do anything suboptimal for any of these patients. Do not do something that doesn't work in long run. And V-plasty to me is a sham procedure. Just give it time. It is going to get better. Usual biomechanics do not work in these patients. So karo kya? V-plasty mat karo. Short segment fixation mat karo. Standard biomechanics pe believe mat karo. So karna kya hai? This is the time to think out of the box. Innovate. Innovate. And before you innovate, follow this strategy number 1, 2, and 3, which is make these patients overall healthy. They are not only osteopenic, they are also sarcopenic. They are low in nutrition. They have severe osteoporosis. General care is absolutely important, and fracture prevention is absolutely paramount. Give them the advice so that they don't develop any further falls. They don't develop any further fractures. And the most important key, I think we all the speakers, Dr. Vikas, Dr. Bhave mentioned, is medical management is the key. Today in this era, we are in an era where the problem is of plenty of drugs available to treat osteoporosis, and we must try to optimize medical management of these patients even before we rely upon either a vertebroplasty or a short segment or a long segment fixation. And as I said, fracture prevention is the best thing that you can offer to any patient, even with neurology. You got to arrange for things where patients have a tendency to fall. You got to make sure that they don't fall back again when they are back home. And out of the medication, there are so many. Dr. Bhave highlighted some, Dr. Vikas mentioned some, but the answer to this is combination therapy with anabolics and bisphosphonates and various other agents. Try to start as early as possible, be as aggressive as possible. And when it comes to surgical strategies, I would like to reread the lines again. Progressive kyphosis is going to happen. You got to partially correct them. Don't try to overcorrect it, but do tend to correct it at least partially. Augment the caudal and cephaloid vertebrae. Try to have maximum fixation points, ideally 3 above and 3 below. And this is all mentioned in these wonderful chapters in books also. There are multiple number of papers to highlight that minimum 3 anchors above and 3 anchors below is rule number 1. Rule number 2. Every screw must be augmented by one or other method. Wiring is the most economical, one of the best methods in osteoporotic spines, where you must augment their fixation points using wires in sublaminar conditions, where you can actually get better hold of not only the vertebral body, but also posteriorly, and implant cutout rates can go down significantly. Vikas showed some wonderful screws which are cement augmented, is one of the ways where you can augment the strength of these screws. So try to augment all anchor points that you have, but at least do it for caudal and cephaloid ones, and try to augment the fracture. You may want to augment it with cement, ideally with a graft, but if sometimes you're not able to do like in a pincer vertebrae, try to just resect it and do a cage, but try to augment it anteriorly for sure. If you are not following these principles, you are doing something suboptimal, and that's why long segment fixation in these patients which are having issues of kyphosis neurology is the rule as of now. And there are multiple such papers. I can just show you so many papers. I have been practicing this. There are papers which have mentioned 3 above, 3 below, multiple fixation, augmentation, and anterior support is absolutely mandatory to prevent failures. One such very similar example where we did anterior transpedicular grafting and 3 above, 3 below with the interfragmentary screw. Remember that vertebral body, even after taking the graft, can still hold a screw in there. You have packed it with graft there, and you can see the result, how we have been doing it here. And these are the x-rays which show wonderful fusion there without any case subsidence. We have done everything that could have been done. Transpedicular grafting, long fixation points, augmentation of with sublaminar wires here, sometimes with cement, sometimes with some other methods. Here we were not able to reconstruct, so we just went and resected and put in a case there. Again, 3 level above, below, in a 78-year-old female who had early neurology. These are all dynamic neurological patients where patients develop neurology when they stand. Again, another patient, post-vertebroplasty instability requiring 3 above, below. See the augmentation done at the superior level. Another patient where again augmentation required at the superior and the inferior level, either with a hook or a sublaminar wire. And this is what we have published with 54 of our patients with whom we followed up for 2.5 years. There's not a single patient where implant cutout happened in all of these patients. Yes, some amount of subsidence does happen. However, this subsidence doesn't translate into your implants failing over a long period of time, all up to 30 months of follow-up. And this is what we have shown in our results. So if I have to summarize my strategies here, if you have to do something, give time to the patient, medically manage these patients, treat osteoporosis as the primary thing. These are all medical problems. They'll get better sooner than later. Keep patients as a surgeon. And if you have to do something optimal, which involves minimum 3 above, below. Try to have as much augmentation as you can and try to correct the deformity as less as possible. Thank you so much, Shailesh.
Thank you, Vishal, for your rule breakers and wonderful presentation about medical management and long segment, how it really scores over the others. But I think what Dr. Bhave spoke about, his indications for the fractures, what Dr. Vikas spoke about the short segment and your long segment. I think the one person who is confused today is not Dr. Nene, it is Dr. Pramod Bhilare, and who is going to talk about evidence. And I'm sure now he is puzzled about, who is right and who is wrong. So I think it's an indication, it's a selection of patient in these osteoporotic challenging cases, and no one is right or no one is wrong. And that itself makes you a winner. And I would like to request Dr. Chhabra sir to share his pearls of wisdom. Dr. Chhabra sir.
Yeah, I think it was a very interesting debate, but can I ask one question from the 3 speakers? The same question, right? What percentage of all osteoporotic vertebral compression fractures, right? I'll ask 2 questions, are symptomatic, right? As reported in the literature and as per your experience, what percentage of osteoporotic vertebral compression fractures are symptomatic? So I will do the reverse order now. First, Vishal.
Sir, I think I completely believe in the natural history, and I really agree that 95% of our patients will surely settle down in 3 months' time.
Fine. Vikas?
Sir, I also resonate with Vishal. I think we all believe in the same thing, that most of the patients would settle down with medical management and conservative management.
Dr. Bhave, you agree, right? So because there are our young colleagues who are watching also, and since we are discussing fixation, vertebroplasty, the message should clearly go that the vast majority of osteoporotic vertebral compression fractures will heal with a conservative treatment. In fact, the vast majority are not even symptomatic, and you miss them, right? You see them later on in any evaluation for a chest X-ray or whatever. My next question would be, right, and I will start with Vikas now, and then the others can answer. What is the percentage of symptomatic osteoporotic vertebral compression fractures which have not responded to conservative treatment, which will require a fixation? Vikas?
So difficult to give a percentage wise, but majority of them would settle down with conservative. And percentage wise,
I'm talking about those which do not respond to conservative treatment. What percentage of them will require a fixation? It is reported in the literature, but still, your experience and literature base, right?
I would say more, if they are not responding to conservative, then probably they would settle with a smaller version of surgery, like what Dr. Bhave was speaking. So I would give a percentage of 10 to 15%, not more than that.
Who require a fixation?
Who would require a fixation?
Shal?
Sir, I think symptomatic patients who are not neurologically challenged, there is no deformity and there is no established cumulus lesion. I think those are the patients I'll just continue waiting, even if they have pain in there. These are all lost battles. So intervening.
Very debilitated. 12 weeks of conservative treatment, severe pain, right? Not responding to conservative treatment. So would you still continue with conservative?
No, I think there are so many factors that I'll surely put in mind in here. The question is, why has she not healed? And whether it is instability at PLC level, whether it is a pseudoarthrosis anteriorly.
No. My question is direct, Vishal. What percentage of people fall into those who would require a fixation?
I think less than 2%.
Fine.
Of 100 osteoporotic fractures, I think less than 2% will be the actual ones who will actually require fixation, a long-term fixation to come out.
Those who fail a conservative treatment.
Yes. Yeah.
Right. So, see, the message again is clear, right? You cannot wash away any particular kind of treatment. There is a role for everything, right? So what everybody talked about a good management of osteoporosis was common to everyone, and that is something which we should never miss. So you have to treat the cause rather than only the fracture. So I think this is a very important point that even though we talk about it a lot, we often miss, because it is well reported in the literature that 85 to 90% of osteoporotic hip fractures just undergo a surgery and do not undergo a osteoporotic treatment. So I think this is one very important point. The second, everything has a role for itself, whether it is vertebroplasty, kyphoplasty, short segment fixation or a long segment fixation, everything has a role for itself. But as agreed by all the speakers, most of the patients who fail a conservative treatment and require a procedure will benefit with a vertebroplasty or a kyphoplasty. There would be indications for a fixation. What you need to see, I feel, are basically two very important things. One is whether there is a neurological deficit or not, right? If there is a neurological deficit, there is no way you can do just a vertebroplasty or a kyphoplasty. But again, mentioning that these will be in a small percentage of patients. The other would be the kyphotic deformity. If there is a significant kyphotic deformity which is not correcting also on a dynamic X-ray, then you should not just do a vertebroplasty or a kyphoplasty. And one of our fellow faculty here, many of them have published, I think the paper by Abhay and Patil was wonderful. What are the factors which would predict that it will progress to a significant kyphotic deformity? Involvement of superior end plate and thoracolumbar fractures are at the highest risk. I think Abhay is here and is listening, but he can better say so. I'll just try to summarize. Then if you have anterior cortical breach, right, or if you have an adjoining level fractures, I think, Abhay, have I summed it well? These are ones which have a significant chance of progressing with the kyphotic deformity. And of course, if you have both end plate fractures or a vertical split, these are ones you should consider definitely fixation along with cement augmentation. Abhay, would you agree with that?
Sir, you nailed it. Thank you so much.
So I think the message should go out crystal clear. Treat the osteoporosis. There is a definite, in fact, conservative treatment has a definite role. Those who do not respond, vertebroplasty or kyphoplasty would be required in most of them. And what was initially considered to be also an indication for surgery means posterior cortical breach, right, without neurological deficit. Now you can do an eggshell procedure and you may go in just for a kyphoplasty or a vertebroplasty. But there would be definite indications for fixation, that is neurological deficit, or those which may progress with kyphotic deformity. If you have to define also what is short segment fixation and what is long segment fixation. I believe short segment fixation would be one above, one below and an intermediate screw. Anything more than that would be a long segment fixation. But if there is a global, if the sagittal balance is getting affected, even otherwise in osteoporotic patients, you would consider a long segment fixation. But you have to consider other factors also. As Dr. Bhave said, most of these people will be geriatric patients with severe comorbidities. So that also needs to be taken into consideration. I think I overshot my time. I apologize, Shailesh. I think there is also later evidence-based talk which is coming. So over to you.
But sir, very nicely summarized and question based, and that was really a very good thing that every one of us have understood that these debates are mainly for patients who need surgery with a proper indication. most of them will settle with good medical management, and every one of us will agree for this. There is no question, there is no second thought. And thank you to Chhabra sir for this great word of wisdom. And I would like to start the second debate. And we have the guy who was confused at the beginning, Dr. Nene, and he's still confused for the multi-level lumbar spine and listhesis, stenosis, deformity in lumbar spine, and whether we should consider standard posterior surgery, which we are doing with great outcomes, or we should adapt the new techniques and technology such as OLIF. We would like to know from Abhay.
So I don't have the answers. I'm going to give you my confusion because there couldn't have been a better topic. I mean, if osteoporotic fracture causes confusion in my head, this topic is the mother of all confusion. And the adage of more study, more knowledge, more information, more technology equal to more confusion can't be better adapted anywhere else than in this topic. Because see this, my friend's mom who had operated some months ago, obese lady with a who deserved her surgery. And sure enough, I had a fantastic X-ray to show. I did a conventional Gautam Jhaveri operation where you go from the back, do multiple level T-lifts and come out proudly thumping your chest and showing a great X-ray. And you don't really read between the lines that I lost 2.5 liters of blood while I was operating. I was in there for 6 hours, sweating, fuming, cursing. There was a drop in BP during surgery. There was a there was a drop in urinary output. I don't talk about that. And I published this case without actually going forward with the result. Wound infection, adjacent level fracture, neuro deficit because of the adjacent level fracture, and tail in with COVID-19. This is a serious mess. And I'm sure Gautam is, hiding somewhere in the, behind his small phone. But I wonder how he's going to defend such big operations that we conventionally do for this pretty bad scenario of an adult scoliosis. And my dear friend, Dr. Amit Jhala, is obviously sharpening his blade. He's saying, ye sab hone wala hai, aisa sab operation mat karo, and do what I say. So here's a prize case for you, Amit. It was a lady who'd had a long-term follow-up of a well-done PLIF. She came with an adjacent segment instability, no compression, as you can see, but significantly disabled. I conserved her for almost 3 years. And eventually she came asking for an operation. Clearly, there's no decompression needed here. She's symptomatic, on loading. And this makes a case for OLIF. Now, the OLIF guys say that, a case like this should be done OLIF plus TLIF. It's like, it doesn't make sense to me. Either you go OLIF or you do behind. Why do you want to do 2 surgeries for someone who can do one, who can get away with one? And I chose Amit's, Amit, the sharpshooter. I chose his option and I went and did an OLIF alone, and popat ho gaya. Very soon everything started to give way, and I cursed myself and I said I should have followed the big man, Dr. Jhaveri, and should have gone behind. So if confusion is the first step to knowledge, I'm the genius here because I'm completely confused. I'm completely flummoxed as to what the guidelines are and, how am I going to deal with these cases where OLIF and TLIF is an option. And I'm really dying to hear from the experts if they can solve my confusion. Over to you guys.
Thank you, Dr. Nene, for a real confusion, and we were really puzzled, all these things, scenarios are there in everyday practice. And let's hear from the man himself, the man who does a lot of OLIFs and who pioneered it in India, Dr. Amit Jhala. We would like to know from him. The debate starts now. Over to you, Dr. Jhala.
Okay, thank you very much, Abhay, for a nice case that you showed for an OLIF problem. I'm going to share my screen and going to show how, and what are the intricacies for doing an OLIF and why the OLIF is the best according to me. Now, what we are going to talk about is not only adult deformity, what Abhay was depicting, but we are going to talk in general about multi-level lumbar listhesis and stenosis. Of course, adult deformity will be part of it, of this. So the cases that usually that we see are the patients usually come with a stenosis. They are old age, they have a lot of comorbidities, and sometimes they are neglected in our country, and they come with multiple
multiple level issues, and OLIF or TLIF or whatever you want to do, the primary indication for them is an instability. So unless you have an instability, there is no point doing any type of a fusion. So what we are primarily discussing is the patients with a multi-level stenosis, as is depicted in all these pictures, that you have instability along with a stenosis. So that forms the primary category which we are going to discuss. Of course, they can be having a listhesis, or they can be having a kyphotic deformity as is shown here, or they can be having a gross adult type of deformity. And as in the cases of an osteoporosis, I think adult deformity, whatever we do, we want to escape from this type of deformities rather than stick to it like in osteoporosis. So I'm going to discuss about it all. So the primary thing what we require in this lumbar canal stenosis is decompression. So the patient has come with a claudication, and we need to decompress anyhow. So that is the primary aim of our goal of these type of surgeries, is a decompression. And because either before a decompression or the patient has got an instability, we require a stabilization if there is instability, or if we remove the facet for a foraminal stenosis, then we require a stabilization. So that is the second important goal in these type of patients, that we require a stabilization along with a decompression. But whenever the word stabilization comes, there is always a problem, and we require to stabilize these segments in a good spinal alignment to get a long-term outcome, right? If the spinal alignment is not perfect, then definitely whatever the surgeries you have done, the patient will come back either 1 year, 2 years, 5 years later with other problems that everyone knows, that the problem of loss of alignment can give rise to adjacent level or a proximal junctional kyphosis. Now, as we said, that these patients are usually old age, and the old age patients do have a lot of comorbidities associated with them. So age is a problem. They have a lot of comorbidities like diabetes. They have a cardiac issues. And of course, the problem of osteoporosis by itself is also there in these old age patients. So whatever we need to do, we have to take it as a risk-benefit ratio, but more the minimum, better it is. That is what I think we have all come to a conclusion in old age patients. So we need a procedure which is the least invasive because there is a lot of morbidity of long surgeries in an old age patients with comorbidities. So these are the 4 important things or pillars on which I'm going to talk. Now it is really confusing. You see, this person is standing on one side and he can see 4 sticks. The other person is standing on the other side and he's going to see 3 sticks. So I think it is the perspective which is different from both these persons, that somebody will see it as 4 and somebody will see it as 3. And you are really confused. Both are right in their own way. So whether you do an OLIF or an open posterior, both have got their own pros and cons, and they have got their own indications, what I would say. And that is where we will end the debate in these cases. So as far as Gautam is concerned, we do not fear the unknown. We fear what we think we know about the unknown. And the Gautam, unfortunately or fortunately, I have traveled in the evolution from the full posterior approaches to a minimally invasive and now OLIF. And while Gautam is an untraveled path, so I will have to look for more theoretical problems, what he is going to talk about, and the practical problems that I faced. And therefore, if you are talking about a lot of analysis, you get a paralysis of an analysis. So you just try to analyze why not this procedure and why this procedure, and you will never come out, and you will be paralyzed with one particular procedure, and you will never come out of the comfort zones. So I think it's very important to come out of these comfort zones to find out what are the problems of the newer things. Coming to my further talk of the conventional procedure TLIF, I think everyone knows that TLIF is a gold standard, and you have a good decompression, stabilization, alignment with a good fusion rate all over. So I am not against a TLIF, but if you see a multi-level procedures, and if we do a multi-level procedures, we have a loss of lordosis here, there's loss of sagittal alignment, and you can get a very good correction by all posterior. That is what conventionally that we are going to do. But you can see that once you get a good lordosis, even with this, if you don't have an anterior reconstruction, you can see everything is opened out here. All the anterior structures are open. So biomechanically, though you can get a result, this construct is going to fail in future. And therefore, the next stage is to do an all posterior, along with what Abhay said was to do an anterior interbody fusions. So if you want to do a multiple anterior interbody fusions for the reconstruction and maintaining the sagittal alignment, I think these surgeries are having a lot of issues, especially in old age patients with comorbidities. And we all know that what happens is that if you have a long incisions, long surgery, the overall complication rate is around 40% in this kind of procedures, and of MIS, especially in multi-level procedures. I think this is a key where there is a lot of benefit of an MIS compared to the all posterior procedures. You may get a good alignment by the posterior, but there is a lot of complication rate. There is a higher post-operative complication rate if you do an open posterior surgeries in this. So why OLIF? I'm going to talk about biomechanical reasons, technical reasons, clinical, some sharing of my experience and some literature, which will be very less, but I'm going to share my experience. So the first point everyone knows that if this is a stenosis, does this patient require a direct decompression? Patient comes for a decompression procedure, and if you just stabilize, and if you don't do a decompression, I think your surgery is going to fail. So whether this patient requires a direct decompression or not. So initially, even I was confused whether I will be able to do the same procedure, but gradually with evolution, I found out that if just by putting an anterior cage, jacking up the disc space, you can get a very good indirect decompression with a reversal of the disc bulge, stretching of the ligamentum flavum, distraction of the facet joints with an intact lamina. And this is very important in multi-levels, because mind you, multi-level, whatever you do, you have to revise. You have to revise after 5 years, 10 years if you are doing multi-levels. And therefore, whenever you have a very good native place to go again for a second revision, I think intact lamina is very, very important in these cases. If you see the lateral, you have increased cross-sectional area just by putting the cage and jacking up the disc space. And you can see that there is a good alignment. The listhesis also gets reduced, and you can get a good reconstruction of the spinal canal along with a good disc height and a good listhesis reduction and a good lordosis. So these are all the advantages of an OLIF procedure at a single level, but you can repeat it at a multiple levels to get a good results. The other issues that I face with a TLIF is there is a lot of subsidence, because these cages, if you see, this is a CT scan of a patient having a TLIF cage, and you can see the cage is absolutely in the center. But you know that in old age patients, this central part is never enough to prevent the subsidence. And that's where the advantage of a long cage, which goes from an end plate to end plate, which is the strongest part of the bone, which can give a good hold of the cages, and you will get a less subsidence. So biomechanically also, these cages are much better, which will decrease the subsidence rates and which will maintain whatever the sagittal balance that you have got in the future. The third point that regarding the approach of TLIF is it's a more destructive approach. Whenever you do a TLIF, the things which are not required, you are doing just to put in the cage. That means you have to break the wall of the spinal canal. That means you have to go through the facet. And once you go through the facet, you are damaging the posterior muscles, you are damaging the facet joints, and then you are entering the disc space just to put in the cage. And this can give rise to a lot of epidural fibrosis. There's a chance of dural tears, neural injuries, more back pain. So these are the concepts on which the OLIF is much more gaining. So OLIF is a perfect procedure for multi-levels. That's what I feel. You get a good indirect decompression. You get a good fusion because of the better disc clearance, better implant positioning in a biomechanical position. You get a better grafting, and all can be done in MIS way. There is no muscle cutting. I think this is one of the procedure where there is no muscle cutting at all. You just split the muscles and go inside, and you will be reaching the disc. You will be reaching the disc space. So there is no bony resection, no dural leaks, and minimal back pain. Mind you, this is not studied very much, but the patients with an OLIF are much better compared to the patients of TLIF post-operative as far as post-operative pain is concerned. So these are one of the very simple cases, and everyone will say that this requires just a stabilization. There is no need for decompression. And it's a very good case for an OLIF achieved without entering the canal. So I think that is one of the most simplest case that one can have. But this is not what we are here to discuss. And everyone wants that what happens if there is a HS D or a very severe compression, whether this thing is going to work or not. That's the situation too. And you can see that it is the same patient's immediate post-operative MRI. And you can see we have not entered the canal. We have achieved a good lordosis, good disc height. We have also achieved a good canal clearance. Of course, this is not all the way. This is one of the cases that I'm showing. But you can get a good stabilization and a good alignment as well as a decompression in these cases. So how much is the indirect decompression? These are literature, and there is ample of literature. You can just go through these literatures, and everyone has said that there is no patient requires a direct decompression. All the patients are clinically improved unless the patient has got a bony. So your selection of the procedure is very, very important. If there is a bony stenosis, if there is a tethering, you are not going to get the indirect decompression. So the point number one is adequate decompression is achieved without entering the canal, and there is no need for a direct decompression. So once you are convinced about the decompression, you can just go for multiple levels. Now the second point is how much sagittal alignment that we can get. That means how much lordosis is achieved per segment, either with a TLIF procedure or with an OLIF procedure. Because then if you just build on one segment to segment, this is one segmental lordosis which is going to give you how much you can get it. And this is a very good study, and they say that one level TLIF will give an average 2.1 degrees of segmental lordosis. So if you do it at 3 levels, you can get a 6 degrees of level lordosis. And this 6 degrees is not going to compensate for whatever you want. So you have to, whenever you are multiple, if you want a lordosis, then only cages are not going to work. You have to do something extra for that. While the lateral cages give a better lordosis compared to the TLIF procedures. And this is one of the articles from Anand, and according to him, his article, you have a 8-degree lordosis when you use a 12-degree cage per level. So if you just put a 3 cages at 8 degree, you can get a 24 degrees of lordosis. So the PI minus LL mismatch can get better corrected just by putting the cage. But this is not the case that we have in India as on today, because we don't have a good 12 degrees or 16 degrees cages or 20 degrees cages that are available. So what we have published is of the 6-degree cages which were available. This is 2019. And we got a segmental lordosis of 3.4 degrees with 6 degrees of cages. So PI minus LL mismatch that can be compensated maximum with Indian setting cages is around 20 degrees. So that's what the limit that you have to agree upon when you are doing these things. So advantages of the lateral access in multi-levels is definitely multi-level anterior fusions can be done by a very small incision. That means you can approach at least 2 and maximum 3 levels for a single anterior incision. You get a better sagittal alignment by inserting multiple cages anteriorly, get a better fusion and get a good indirect decompression. So these are the advantages of the lateral access. So now coming to some multiple or double level cases. This is a double level foraminal stenosis, patient having a lytic listhesis with a double level foraminal stenosis. And you can see you get a very good disc height correction. You can get a good alignment, a very good alignment of the spine as if it is a natural alignment. And as far as the fusion is concerned, this is 1 year post-op CT, which you can see that you have a very good fusion also on CT scan. Another patient, male 65 with again a double level lesion of a listhesis. You can see a severe stenosis. We just did a double level OLIF procedure, and you can see a very good alignment. Of course, the stenosis is gone, but the most important thing in multi-level is to get a good alignment, and you can get a good sagittal alignment. I'm just building on 1 level, 2 level. So this again a double level stenosis with a moderate amount of stenosis. You can see at both the levels 3, 4, and 4, 5. And that's the post-operative MRI, which also gives a good, you can see good alignment of the spine and the correction of the listhesis also. Now, if you want to do such an obese patient, just to put the patient prone is a problem. I think the best way is you can do this OLIF procedure in this obese, just put the cages in this also, and you can get a very good post-operative alignment. Of course, there was no much of a compression here, so it just required a stabilization in this case. Again, a patient having a double level listhesis, but no disc space at all. There is no disc space at all, but you can just reconstruct the disc space. That's the post-operative MRI, and that's a 2-year CT scan. You can see that the disc height is absolutely maintained even at the 2 years with a very good fusion rates. So I think these are, and the whole point here is that double level can be done by just single incision of about 3 or 4 or 5 centimeter max, and posteriorly they are just stabs for percutaneous fixation. And the point number 2 here is multiple cages can be inserted through single small anterior incisions, less invasive than all posterior. Definitely, there is no doubt about it. There is a good segmental alignment of the spine. You get a better anterior fusion in biomechanically sound position, and you get a good indirect decompression. So these are all the advantages. Coming to the last part is the adult spinal deformity. It is a best approach for the adult spinal deformity because you have to build upon no more than 3 levels. Excellent regional as well as global sagittal alignment. You decrease the morbidity of the surgery because the patients don't require an osteotomies. If you want to reconstruct the sagittal alignment, sometimes just TLIF is not going to be enough. So you require an osteotomies, and this can be avoided by the OLIF cages. And it's important to decrease the surgical morbidity in these old age patients. That's one of the key advantages of an OLIF procedure. And definitely, because you get a good alignment, you can decrease the chance of PJK and adjacent segment diseases. So this is a patient having a kyphotic deformity with a multi-level stenosis at 3 levels. We just did 3 level. These are the pelvic parameters, and you can see 21. Lumbar lordosis, what post-operative we got was 45. And SVA, which was negative, we got a neutral SVA. So that's the 3-year follow-up of the same patient. You can see a good fusion, and you can see exactly how much a good alignment. You can see that there's thinning of the ligamentum flavum. So as years pass by, your decompression is much better. Coming to another patient, adult deformity, you can see there is a positive SVA, and she's a doctor. We did a staged procedure. In first stage, we just put a 3 cages, and then in second stage, we did all CMIS, that means all percutaneous screws. You can see the difference that we got from this much SVA, and we could get a nearly normal, and PILL mismatch was now 7 from 25, which was pre-operative. And that's the sagittal, the axial or coronal alignment also. That's what we got. This is another case, a gross change in the SVA. And again, with this, we got the same type of result that we got back the SVA. So just one literature, there is ample of literatures which have compared these 3 surgical strategies. But the point is the same in all the literature, is that LLIF has lower rates of PJK, mechanical failure, and the patients have less back pain, less disability, and a better SRS score. So I'm not going in much of the literature, but this, I think the next speaker is going to take on the literature. But one particular thing which I want to just show that how it is evolving, the ASD surgery is evolving from 2009 to 2016. And one can see that the 3-column osteotomy utilization has decreased from 36% to 16.17% in 2016. And that was because of lateral lumbar interbody fusion, which was introduced in 2009. And then the rate of that surgery has increased, which has decreased the osteotomy for the adult deformity. And you know that the intraoperative complications have also decreased from 33% to 9%. And the overall complication rate also has decreased in these patients because of this thing. The last case, what Abhay showed, I'm just going to repeat that case. This is a patient having in 2011 had a double level light thick listhesis. and a double level fusion was done, anterior fusion was done with a cage. In 2018, the patient presented with a severe bilateral claudication, and we got a double level adjacent segment disease. And you can see that we just did the same procedure. This is double level, so I just augmented one L level anterior and the rest the posterior. But one thing I want to answer about the Abhay's case, that whatever the implant that you used, the Pivox, I have already failed in 3 cases while using Pivox before 3 years, and I've stopped using the Pivox. Pivox never works. The screws are not good, and the plate design is also not good. So I have stopped using Pivox, and I'm just using our regular routine screws, which have a better hold. These screws you can use is 6.5 or 7.5. So they are much better compared to the Pivox plate that you showed as a confusion, right? And this is a 2-year post-op of the same patient, and you can see a very good canal clearance in this patient, also in adjacent level. I think this is one of the great case for OLIF procedures, because you don't have to open all posterior. So there are issues that there are a lot of complications of OLIF procedure. I think that if you start any new procedures, as the procedure you start evolving, you will get initially some complications, which also I have faced in my evolution phase. I have faced nearly all the complications, but now the complications since last 2 to 3 years have substantially come down. This is one of the 2019 articles where they studied 2,429 segments, and everyone is worried about only one complication is a vascular injury. And see, the vascular injury is only 0.3%. So I think there is a lot more other complications which are there in posterior compared to just fearing a 0.3% of a vascular injury. And the overall complication is 8.2% at 1 year with OLIF. So I think as you evolve, you know how to select the cases. You can avoid the vascular injury. Nothing is blind there. You can see the vessel and you can go accordingly. So vascular injuries, you need not worry at all once you start becoming experienced about it. And I don't think an OLIF is a newer procedure for all the stalwarts who are present as a panelist here, because it's an age-old anterior approach that everyone was doing way back. It's just a minimally invasive way, or a near way it has come. So it's an old wine in a new bottle. So the man who says he can and the man who says he can't are both correct. So I don't say that the OLIF is the only way you can do it, but you have to select your procedures, because you require the posterior procedures whenever the deformity is quite severe, or SVA is more than 30. I would be more specific there. But otherwise, in mild to moderate deformities, I think OLIF is the best choice compared to the others. So what I use a balanced approach is, don't do a posterior approach when there is no OLIF corridor. There is a severe osteoporosis. There is a severe stenosis of grade 4 or a bony stenosis. If there is a congenital stenosis, if there is a posterior teeter already there, just do a CT scan and find the facet joints are fine. And at present, I don't do it at L5 S1 because of obvious reason that we don't have the set at present available. And clinically, this patient should fit into a claudication and not to a radicular pain with an SLR positive. And the patient should have all these things which I have already shown. Thank you very much.
Thank you, Dr. Jhala, for a wonderful presentation. It was indeed an eye-opener for most of us, and what a marvelous cases and selection you showed. We have Dr. Gautam Zaveri with us. Hello, Gautam sir.
Hi, Shailesh. Pleasure to be there.
Yeah, and
can you hear me?
Yes, sir. Perfect. So we would like to hear from Dr. Zaveri about his views on posterior surgery, and we have kept some cases backed up by Dr. Vishal Kundanani for the posterior surgery as well. How would you like to go?
Thank you, Shailesh. Shailesh, I would like to thank you and the entire team who's organizing this meeting for inviting me here today. I'm sorry, there was a little bit of misunderstanding. I thought that this presentation was on next Saturday, and I'm actually on vacation right now in the mountains. And I'm not sure if my internet connection is going to be good enough. I certainly don't have a computer to make a presentation. So I'm just going to belabor some of the thoughts that I have on the topic that is there. When you talk about a degenerative lumbar spine, which requires surgery, aside from a slip disc, you're talking about basically 4 scenarios. You're talking about a simple lumbar canal stenosis at a single level. You're talking about lumbar canal stenosis at multiple levels without any instability. You're talking about a single level spondylolisthesis with stenosis. You're talking about multiple level spinal stenosis with instability, and the final would be an adult spinal degenerative scoliosis. So let me tell you, do these patients. For a single level simple lumbar canal stenosis where there is no instability, no facet joint diffusion, nothing which is compelling me to think of a fusion here, I would want to do a simple decompression operation. Now, this simple decompression operation could be a conventional laminectomy in order to decompress the spinal canal. It could be an interlaminar fenestration. It could be an interlaminar fenestration with an over-the-top decompression. The choice is yours, whichever way you do it. The goal of surgery is very clear. Decompress the neural elements without compromising any instability of the parts. So do not remove excessive bone, which can result in instability, but make sure you do adequate decompression. And when doing the decompression, do not cause injury to the neural structures. As long as you are doing that, there is no reason here to think about doing anything more. A number of papers have come out talking about the use of OLIF for single level simple lumbar canal stenosis. They have talked about increasing in disc height. They have talked about radiological measurement of the foraminal height. They've talked about increase in the lumbar lordosis. What they have not talked about is, does this really amount to a better clinical outcome in these patients? And the answer is no. A simple decompression for lumbar canal stenosis is one of the best procedures that we know. And there is no need to fuse such a spine with loss of movement, with the risk of adjacent level problems. And when you are fusing the spine, there are associated complications. No patient, whether you do even a minimally invasive procedure like OLIF, will result in the happiness that a person will get with the lumbar canal stenosis decompression. The long-term outcomes of this are well known, 80% good results at 15 years. So I don't think there is any doubt in anybody's mind that for single level, simple lumbar canal stenosis decompression of the procedure is the treatment of choice. We then go to multi-level lumbar canal stenosis. In the absence of anything which will lead you to think of instability or other problems, again, the procedure here is a decompression at multiple levels. How you choose to do the decompression is yours. Again, the goals remain the same. A very good decompression without causing severe instability and without damaging the neural structures. The decompression can be done laminectomy, interlaminar. You can do a spinous process splitting approach, or you can do an over-the-top decompression. Bear in mind that as the number of levels of decompression increase, the over-the-top decompression procedure becomes much more onerous and it takes a longer time and therefore may result in more complications and inadequate surgery. So it's even multi-level, but also 2 more points, I think, for the younger surgeons who are watching this. Whenever there is multi-level stenosis, try and identify the significantly painful level and see if surgery can be restricted to that level rather than doing multi-level surgery. When there is multi-level stenosis, always get a CT scan done. Look for any ossification of the posterior annulus, etc., which would indicate to you that there is no acute disc herniation in these patients, and do not attack the disc in these patients. The second thing is that a lot of people think that the more level you decompress, that you definitely have to instrument and fuse the spine. This is completely wrong. The more you decompress, the more levels you decompress in a stable spine, the less you should do fusion, because the chances of complications increase with fusion. Multi-level fusions are a bad thing for a patient, whether you do OLIF, whether you do anterior ALIF, whether you do PLIF, TLIF, whatever procedure you do, multi-level fusions are bad surgeries. So try and restrict your surgery if it's a multi-level. Do your best attempt with root blocks, facet blocks to see if you can restrict your decompression to a single level. If you can, fantastic. If you can't, do a multi-level fusion, bearing in mind keeping the patient's structures which provide stability intact. Again, there is no proof here that by improving the lumbar lordosis in these patients, you are improving their long-term back pain, reducing the risk of recurrent stenosis in the future. So if people say that, oh, we want to do a multi-level fusion in these patients because it would reduce the risk of recurrent stenosis, that is not true. So that brings us to the third clinical scenario, and that is a single lead level degenerative spondylolisthesis, and with this a spinal stenosis. Again, a beautiful surgery, a simple TLIF procedure. So here Dr. Jhala did mention that you are going through the L4, you are excising the medial facet and a part of the lateral facet in order to access the disc space. But that is the level you are going to fuse anyway. So where is the problem with one in the front and one in the back? And certainly they are not ready for any uncertainty in terms of telling them, oh, you know, we will do the surgery from the front, but in case your symptoms do not get relieved, then we may have to do a posterior procedure for decompression subsequently. That sort of uncertainty is not acceptable. And that Dr. Jhala will be the first to accept, because I've heard him in multiple talks on OLIF where he has said that all patients have to be explained, because a small percentage of them will have persistent symptoms even after you have done a decompression, and then you have to go in posteriorly and decompress these patients. So in my case, I prefer for a degenerative spondylolisthesis a minimally invasive mini TLIF using tubular retractors or an open TLIF. Even if I do an open TLIF, my incision is very small. I do a nice decompression and instrumented transforaminal lumbar interbody fusion, and the results are fantastic for properly selected patients as long as you do the procedure well. In these patients, for a single level stenosis, the amount of lumbar lordosis that you recreate with the interbody fusion has not been shown to affect the clinical outcomes in any way. In fact, the more lordosis you recreate, the higher is the risk of adjacent segment degeneration. So you don't actually want to do, because now all the load shifts to the level above. The level above goes into slight amount of kyphosis, it degenerates and causes more problems. If you looked at the cases which Dr. Jhala showed, almost all the cases where he has done OLIF and increased the disc height, there was a huge facet joint white signal which is showing a hyperintensity signal within the facet joint, indicating disruption of that joint when distraction was done over and above what was acceptable to that particular joint. So single level TLIF is a fantastic procedure. The results are very good, and the complication rate is less than 1 to 2%. Again, Dr. Jhala would agree with me that the incidence of single level reported by Lee et al. Is of OLIF complications is almost 30%. These include psoas muscle pain, psoas muscle hematomas, They have reported neuropraxias. They have reported vascular injuries. They have reported end plate damage. And I'm not sure what type of patients Dr. Jhala operates on. Because when I'm operating on lumbar canal stenosis, these are elderly patients. Their bone density is already poor. And when you do an XLIF procedure, the amount of curating you do of the end plates, etc., results in some damage to the end plate. And invariably, there is a subsidence of the OLIF cage into the vertebral body above and below. So whatever foraminal height you have gained, the disc space height you have gained is partially lost at follow-up. So you know now that if it is lost at follow-up, it also means that the outcome of your surgery is not decided by the increase in height, which has been so well purported by the people who do OLIF procedure. They say, oh, increasing foraminal height, increasing disc height improves the decompression. Also, the moment there is an end plate problem, posterior instrumented fixation is necessary. So nowadays, most of these people say you do an anterior OLIF, follow it up with a posterior procedure. So what could have been done in a simple single procedure, now you are exposing the patient to two procedures instead of doing it in one single procedure. The next and fourth scenario is multi-level stenosis without scoliosis, where there is a slight instability at multiple levels. Again, when you are going and doing a multi-level anterior surgery, now think about it. As Dr. Jhala mentioned very rightly, that anterior interbody fusion is not a new thing. Anterior interbody fusion has been around for more than 100 years. And when I was doing my fellowship in Nottingham in 2000, we used to do anterior lumbar body interbody fusion with an incision which was equivalent to the length of the incision for OLIF. So the size of the incision was about 1.5 inches or so. And we were able to do a nice interbody fusion even with that. And yet that procedure never became popular, not because it was not minimally invasive. In fact, it had lesser risk of psoas muscle damage, neural damage, etc. than the OLIF procedure. But it was realized that it did not make a sense to do a double procedure routinely in patients who require decompression. You are doing a decompression, which is the major procedure, which you have to do from the back. And at the same time, you add fusion to it. So in multi-level fusions, decompression with fusions, generally, unless there is an associated disc prolapse, there is a grossly mobile disc, which I am listhesis, which I am reducing, I tend to do a posterolateral fusion. I don't insist on doing an interbody fusion in those patients. If at all I'm doing an interbody fusion, it is at the level where there is a disc prolapse, where there is a absolutely mobile listhesis or wide open disc space. We will do an interbody fusion there, but at the other levels, we will do a posterolateral fusion. So you don't have to keep on doing multi-level interbody fusions and make it more destructive. So you have to choose your procedure. Whoever told you that doing multi-level interbody fusion is the right thing for such patients? The next thing that he mentioned, Dr. Jhala mentioned, was that you have to do these osteotomies to correct the spinal deformity. He showed 4 cases. All 4 cases were fused only in the lumbar spine between L3 to L5 or S1. None of them were extended into D10. These were not serious deformities. No serious adult spinal deformity can be treated by doing a localized lumbar fusion. If it's a serious deformity, it requires fixation all the way up to D9, D10. All the patients he showed, none of them required an osteotomy. So no wonder they were corrected through a OLIF approach. You would have done equally well if you had done a TLIF with interbody fusion at 1 or 2 levels and posterolateral fusion at the other levels. So don't get misled by this. Finally, when we come to adult degenerative scoliosis, genuinely, when you talk about a severe deformity, imagine the amount of morbidity that this procedure will have when you have to do it at multiple levels, going through the risk of injury to the nerves or the lumbosacral plexus, the psoas muscle, the risk of vascular injury, etc. when you go from the front. And at the end of it all, how many of these patients actually, whether you do anterior, whether you do posterior, whether you do interbody, do these patients actually are completely happy with their clinical outcome? All that we are talking about right now is that, oh, this procedure can be done. What Dr. Jhala is showing you is that, yes, in your armamentarium to treat a patient with a spinal
Amit is giving you some breathing space. You can come to the surface and take some oxygen in.
No, I know that I'm fighting a heavy weight.
No, I think this is a classical clash of the titans. That's what I can say, and no other can be the best people to debate on this. Dr. Jhala versus Dr. Gautam Zaveri, and I must compliment and thank Dr. Zaveri for a wonderful explanation on ideology about the posterior fixation and why he will prefer and not OLIF, and it was wonderful, Dr. Zaveri. I would like to ask for a lot of orthopedic surgeons are watching this. I would like Dr. Vishal Kundani, the night watchman, to quickly refresh us about some cases which he would like to show us about posterior fixation. And again, this is a debate ongoing against Dr. Jhala's OLIF. Over to you, Vishal. Mind it, this is a healthy discussion. This is not a debate, and indications are important. It is just for everyone's understanding. Yes, Vishal.
So are the slides seen?
Yeah.
Yeah. So basically, I'm just trying to make this debate a tri-sided debate. I mean, on one side, there are anterior surgeons. On the other side, there are posterior surgeons. I'm probably just telling you that don't fuse at all. Because that is also one way of looking at cases to show you some cases where I am sure, Dr. Amit, what would you do for this case? 65 female claudication, 2-level listhesis, and the pelvis is already sunk in. I mean, this lady L4-5 is also lying within the pelvis. 5S1 is surely deep down in the pelvis. Lordosis is quite well maintained, and the disc is absolutely stable. No movement at all on flexion extension views.
So, Vishal, how can you be sure that this patient does not have any problem at L5S1 for abdominal stenosis?
No, I'm not saying anything. Right? I'm just bringing a case. I'm a general orthopod. I don't know anything about
science. So you can do it definitely. From my side, L4-5, if at all it was a single level L4-5 problem, you can get away with a decompression. But if there is a L4-5 along with an L5S1 here, with a good amount of a disc height which is there, I would surely like to fuse at L4, 5 and S1. Whatever way you want to, whether you want to do posterior or an anterior, you can do this either of the ways. But definitely, I would like to fuse at L4, 5. But you don't have the CT scan, we don't have the flexion extension views. Of course, they are all the primary things. We don't have the axials, but you can do it.
Another case scenario, 4-5, 3-4, and 5S1. Multi-level stenosis, single-level listhesis. Dr. Abhay, would you like to do a single-level fusion and multi-level decompression, like a long decompression, short fusion, or only decompression, or all levels fusion? Dr. Abhay?
Sorry, I would, do we have x-rays here?
Yeah, I'll come up with that. So yeah, maybe let's take this case scenario. Let's take this only claudication with moderate back pain in a patient with multi-level stenosis and single-level listhesis. Options being only decompression versus short fusion, long decompression versus long decompression, long fusion.
Tricky one. I think if I had to choose in the blink, it'll be short fusion, long decompression.
All posterior?
All posterior, yeah.
Dr. Amit, such case scenarios?
From my side, I feel that there is the listhesis there also, along with disc fragment, or what I am not able to exactly know that at 5, 4, 3, 2, at L2-3, whether there is a disc fragment or not. I don't know about it.
That's L2-3, this one, the first one.
Yeah, so Of course. Then I would definitely do a double. I would definitely fuse right from there to there. 5, 4, 3, 2. 2 to S1.
5, 4, 3, 2. And you're not worried about the L12 disc? Because
Not
that's
at
also
all.
showing equal.
That's okay, because it's already nearly there is no disc space
And
at all.
multi-level OLIF with posterior MIS?
Because L5S1 I don't do it. So once I have to do an L5S1, I'll just do posterior.
Perfect. And how about this case scenario? Let me just take it a little further to the largest spectrum of cases which Dr. Zaveri mentioned. 68 fit male with this kind of X-ray.
I think these are all a settled disc with a very minimal deformity. They just require a decompression. I don't think that we require a fusion at all. There is no instability as such.
Yeah, there is something called as a degenerative auto-stabilization.
Yeah, they are all auto-stabilized.
Yeah. You just do decompression and
just
should
do
be fine.
decompression.
Yeah, so that's the kind of situation. So again, no OLIF?
No,
pre-lift,
not at
posterior,
all.
anterior.
Not at all.
Right.
Not at all.
So I think I just wanted to show about some cases that may come more often in daily practice, where lumbar canal stenosis with settling discs with multi-level listhesis may come to you, where one particular type of surgical option may not work and you may have to have everything in your armamentarium. Like Dr. Amit said, he would do cases for single levels by using OLIF. Gautam mentioned doing it from posterior. Abhay mentioned sometimes using an option of short fusion, long decompression. And like Dr. Amit mentioned, going long all the way and sometimes all posterior. And cases like these are far more common than the straightforward situations where either single level MIS TLIF or single level OLIF is going to work. And for all such situations, another option that is there in practice is all about just doing decompression, only decompression. And why I mentioned this is because there are plenty number of articles to say that whenever there is a word about fusion, there is confusion, and fusion only leads to a place where there is more fusion, and more fusion brings in more confusion. And that's why all the pointers that were discussed here, where multi-level fusion for multi-level stenosis is justified based on these reasoning that decompression alone is either not possible or doesn't yield good result, or listhesis is always unstable and we need to fuse it, or better symptom relief is obtained by multi-level fusion, or fusion gives better long-term result, or giving better sagittal alignment brings good results only. I think all these are just myths. There is enough story about this, that only decompression does works. It not only takes care of claudication symptoms, it also takes care of back pain. It improves the quality of life measures as good as when long fusions or long decompressions alone are done with fusion. Decompression alone does works even in patients with multi-level stenosis, even in patients with multi-level listhesis. Of course, you have to do it in a particular manner where porthole technique without disturbing the posterior tension band is very important. But decompression does works. You just don't have to add any further instability to them. And as I just mentioned, decompression alone also relieves back pain. This is a randomized controlled trial coming from Japan, which mentioned that decompression alone also takes care of back and mechanical symptoms in there. Listhesis is not always unstable. It should not force you to go ahead and do fusion, whether anterior or posterior, because listhesis is sometimes unstable, but most of the times stable. And if you are not destabilizing the stabilizing structures, you can actually just get away by doing only decompression, and utility of flexion extension X-rays comes handy. If there is no mobility, the disc height is collapsed, there is stable segment, only decompression does works pretty well. In fact, multi-level fusion creates more problems than pure decompression alone. Listhesis is not always progressive, because even in patients with frank listhesis, if you do only decompression, only 13% of them will actually progress, out of which 50% will still not require any kind of surgery, proving the fact that listhesis is not always progressive in nature, even after plain decompressions. And as just mentioned by everyone, multi-level fusions have less complication is a completely false myth. Multi-level fusions are known to create more problems. And that is why I would rather think about, whenever possible, just do not fuse, whether anterior or posterior. Think twice whether you are really going to get anything additional by fusing. And if you can restrict your fusion to the bare minimum, to the most unstable segment, which is documented to be unstable, both on flexion extension views, on clinical examination, and of course, radiological pointers to instability are seen, then do a localized fusion for all these situations. Shailesh, I think I just put forward my
I think,
point.
yeah, perfect. Vishal, you really nailed it. And this debate has become more interesting as Vishal wanted to talk about give instability a chance, and not every listhesis is unstable. There are criteria and parameters which one should understand where we should not fuse also. And this is very, very important. I must compliment Dr. Amit Jhala for a wonderful presentation, Dr. Gautam Zaveri for a brilliant impromptu thought process on the posterior fusion and fixation, and Dr. Vishal for a great night watchman's job and giving us a lot of wisdom. Now I would like to understand from the guy himself, Dr. Pramod Bilare, who was talking about, I am not confused because I have the evidence. So let's see what the evidence is talking about. And then we have Dr. Chhabra sir's again point of view before we finish. Over to you, Dr. Bilare.
Am I audible, sir?
Yes.
Yeah. So I think it's been a plethora of knowledge being shared by all the bosses. And thanks to all, my slide numbers have reduced to 1/3 of them now, because a lot of literature has already been on platter and display. And they have been superb in each of them presenting what all is going on in their own genre and era. So coming to this, we are planning to do a kind of metaphorical courtroom drama here. So we have Dr. Nene in the form of Rajesh Sharma, who has raised so many questions to all of us, and we wanted a final verdict or a clarity at the end, whether we are still confused or we sorted our questions well. So this is literature ki adalat. I am just being a novice mere facilitator for this drama. So chapter 1, we discussed about the osteoporotic vertebral compression fractures. It's been discussed a lot by now that majority of them will not require any of the below treatments, and these are the terms and conditions to be applied by all the young surgeons available. So the first episode was Dr. Bhave talking about the vertebroplasty and role of vertebroplasty in this very fracture. So actually we'll go back to 2009. Vertebroplasty is not at all new. It is there since the late 1980s when it was first introduced. But these were the two articles which shook the industry altogether, the vertebroplasty industry, telling probably it's nothing better than a sham procedure, one from the New Zealand, Australia, and one from the USA group, UK group. But then the papers still poured out after 2009, and most of them criticized the RCTs which were published in NEGM, that the quality of the study, the patient selections, the selection criteria, the statistical analysis probably were not used right in a right fashion, and probably that's the reason you got a very dubious results. But after 2009, there has been a plethora of trial studies talking that there is definite improvement of pain scores and quality of life scores, and they are not only significantly better at the early but also at the late follow-up up to 24 months. Dr. Bhave did mention about the excellent results what he had got, but with a pinch of salt that yes, it is not away from any complications, but it is overall less than 2%. The cement leak can be as high as 11 to 70%, but to the good grace, they are rarely symptomatic. The other concern which is shared around the times of vertebral percutaneous augmentation, cement augmentation is adjacent vertebral fractures. Are they really common? Are they really safe? So vertebroplasty, if you see the 2019 update, all the literature till now is consistently showing that the there is a safety profile of vertebroplasty, vertebral augmentation, and all of them confirm that the vertebral augmentation does not increase the risk of adjacent or remote complications. So, what about the adjacent vertebral fractures? Is it so common and so that you should stop doing it? So, if you see the literature review, a systematic review involving 69 clinical studies by Paul Hume, he has clearly mentioned that yes, the adjacent vertebral fractures are tad more than the general osteoporotic population, but when you compare them with the general osteoporotic population that had previous fractures, they fare similar. So when you talk about the pros and cons, talking about the vertebral augmentation, we know that it comes with a lot of advantage. Being a close procedure, percutaneous, decrease the length of hospital stay, daycare, cost effective, no implants, no implant related complications. But the cons has been there, we cannot use this whenever their patient is presenting with a neurological deficit, or whenever their patient is having a deformity which need to be corrected, or it becomes slightly more challenging whenever it is multi-level involvement. And we cannot run away from cement related complications, though they are very rare. They can become lethal and they can be very, very detrimental. And the role of vertebroplasty in acute setting, nowadays we see a lot of patients in surgeons and mostly young surgeons using this vertebral augmentation in acute setting, as rightly told by Dr. Kundanani, that these are the fractures which actually don't require any treatment for that matter. If you give them time, they will heal. So the second episode discussed was regarding the short segment fusion. And I completely agree with whatever Tandon sir has mentioned, that the short segment fixation has a role, but in a select individuals. That as a evolution of the spine instrumentation, we have always not only evolved in terms of having better stability and rigid immobilization, but we have always looked at preserving those motion segments. And in those individuals where it does merit usage of a short segment fixation, wherever like the classifications showed the type 3 and some of type 4, where you might use the short segment fixation. They have shown excellent results compared to the long segment fixation. You can always augment this short segment fixation by using intermediate screw, that is through the vertebra, or you can use them with the help with the vertebral augmentation in the fracture vertebra. So one of the technique which has been mentioned in which has got published in August 2020 from China. A lot of these studies of vertebral augmentation, if you see, is from these Southeast Asian countries, prominently from China, Korea, and Japan. So they have fixed the fracture with short segment with kyphoplasty at the involved segment, and then further augmented with the intermediate screw. What the results showed was there was an improvement in ODI and VAS scores. There was definite improvement in the kyphotic angle and the middle vertebral height, as well as the posterior vertebral height. And there were minimal complications with 2 screw pull out and 8 legs with no consequences. Another study which was did mention during the previous talks, that a similar study from China showed the role of bone segment augmented fixation in short segment versus long segment fixation, and they have found out the short segment fixation has the advantages of shorter operation time and less intraoperative bleeding. But then you are playing with fire here. If the instrumentation becomes loose or the implants backed out, then you are posting the patient for another surgery. So when you talk about the short segment fixation, there has not been a clear definition what accounts for short segment fixation, but something like a 1 level above, below, and an intermediate fracture screw is been widely used by most of the literatures. It does provide rigid fixation. It allows some kyphotic correction, but yes, a major kyphotic or major scoliotic deformity and multi-level vertebral compression fractures, you cannot treat by short segment fixation. And there are many studies it has an advantages that you can do this all these techniques by MISS, that is minimally invasive surgery, saving mobile levels, and an added advantage compared to vertebroplasties, you can do the decompression at that levels. Coming to the third and very important is long segment fusion. I think the chair is already been taken by Dr. Kundanani sir, that he presented a lot of plethora of studies, and actually my talk has reduced to literally 1/3 of it because of him. And I'll just mention a few of the two studies which where one of them had already been said. Is one is the finite element analysis by Dr. Tandon, and where they have compared the full segment fixation whereas a partial segment fixation, and they had found out the rigidity and the rotational stability increases whenever you are doing a full segment fixation, that is 2 level above and below compared to 1 level above and below. Another study by Italy group, that is long versus short segment, which was a retrospective analysis of 37 patients, showed that the VAS and the ODI score had no difference between the two groups, and the bisegmental kyphotic angle was better in the long segment group. Also, there was significant difference in the mechanical complications between the two groups, and which led to a downfall or short segment fixation in certain individuals or certain fracture patterns. When you talk about the long segment fixation, what are the pros and cons? Is essentially same as your short segment fixation, but yes, it does increase the morbidity associated with the surgery, the general anesthesia related morbidity. It decreases the length of the hospital stay, surgical duration, and at times MIS becomes difficult in such cases. Coming to the chapter 2, so here we discussed regarding the OLIF and TLIF. Again, a word of caution here. Here the conditions apply, as rightly been said by Dr. Zaveri sir as well as Dr. Kundanani, that majority of them will not require fusion. They will just require decompression, and it is always better to err on non-fusion surgery because fusion will further lead to further confusions. So when you talk about the literature between OLIF versus posterior only, you can see the fusion surgeries have been evolved from 1911 till now 2021. Almost a century has gone past by, and the TLIF, which was introduced somewhere in the late 19th century by Jürgen Harms and then popularized by Shuffleberger from Miami, we know this approach, posterior approach, TLIF approach, since so long. Whereas the OLIF surgeries or the retroperitoneal surgery is relatively new. Not many surgeons are acquainted or familiar with this approach. It has been the retroperitoneal approach was given by Mayer in 1997 in Spine Journal itself, which was later on coined as an OLIF approach in 2012. So for the last couple of decades, in fact, you can see a lot of articles being published in name of OLIF comparing TLIF, OLIF comparing MIS TLIF, OLIF comparing open TLIF, and there is plethora of articles available in the last 2 decades. Most of them are favoring OLIF in terms of segmental height, disc height restoration. The fusion rates are better with OLIF compared to the TLIF, but the overall outcome, most of them do talk about it, and they say that the outcome between OLIF and TLIF is almost the same, both short term as well as probably not the short term, because the back pain is relatively lesser in OLIF cases in short term, but in the long term this pair well when compared to a TLIF surgery. So a retrospective cohort study, they had found out whether the sagittal balance improves, the improvement in the sagittal balance comparing open TLIF, MIS TLIF, and the OLIF cases. The OLIF led to better correction of the sagittal balance over the open and MIS TLIF, but what has not been talked about in this study is how the outcomes are related to this improved sagittal balance. Another finite element analysis, again from China, where they had used a L1S1 model for these 2 studies, and they found out that both TLIF and OLIF does increase the range of motion and intradiscal pressure in adjacent level, and both of them put potentially increases the risk of ASD with no one faring over the other. Another study comparing the OLIF single position approach versus MIS TLIF suggested that the fusion rate, segmental radiological alignment, symptomatic adjacent segment degenerations are comparable in both the groups. One more systemic review, which a lot being talked about regarding whether the TLIF gives you a better sagittal or a segmental lordosis or overall lumbar lordosis. This is a systematic review comparing containing 47 studies, and most of them, this clearly negates the fact that there have not been a clear literature or MIS TLIF literature showing or comparing these aspects, that is the sagittal balance and how this sagittal balance is impacting the outcome. So when you talk about the pros and cons, especially for TLIF, it's a usual approach. Every surgeon, I won't say surgeon friendly, but more surgeon have seen these approaches over their period of learning for last 30, 40, 50 years. Deformity correction can be done multi-level, open versus MIS, less complication, relatively cost effective when you compare it to OLIF. Where the cons are, it does come with implant-related complication, ASD, less lordosis, and revision. Whenever you are doing a revision surgery, you are going to the same mark for the fibrotic tissue. Chances of complication, infection, dural tears are tad higher. When compared to the OLIF, yes, good interbody segmental lordosis, decreased blood loss and duration of hospital stay. It has a better alignment, indirect decompression. It is also a better surgery when you talk about a revision surgery, because you are going entirely through a virgin corridor. Cons are obviously unusual approach. The cost is a problem because of the implant being at a costly site. But this may not be the only. As the demand increases, the cost will come down. The steeper learning curve is one of the concerning factor, because I'm sure that most of the young generation or the surgeons who have been active over the last couple of decades are not practicing OLIF in their regular practices. And complications, though they are less in an experienced hand, when you start with this complications, it can go, as mentioned by Dr. Zaveri sir, that it can go as high as 30%, but in an experienced hand like Dr. Jhala sir, it may not be true. But at L1, 2 and L5, it is that difficult. So coming to who has won the race. When you talk about all the bosses speaking their heart about for whatever topic was given to them, according to me, all are the winners. There is no single winner here, and have now still confused, but on a higher level. So let me explain this, why they are winner. So the real winner is not only the bosses here, but a good patient selection. They have selected their patient well. Throughout the webinar, you are constantly hearing that this patient they have operated by this indication only because these were the criteria. So even Dr. Kundanani in the end briefed the entire indications for the surgery. Dr. Jhala also explained what condition you need to go for TLIF or MIS TLIF and what conditions OLIF can be done. Now there is more than one way to skin a cat. Do whatever is best for your patient, what works in your hand. And with this, I would say thank you for a patient listening. Stay negative, and we should hope to meet again for the next season of Literature Ki Adalat. Thank you.
Thank you very much for a wonderful presentation, Pramod. And stay negative from COVID. That's what he wants to say.
Yes.
Wonderful compilation of all the scenarios, which was a tough task, and you made it so beautiful, and we understood a lot of things, and it cleared a lot of confusion. I would like to understand from Dr. Chhabra sir the words of wisdom from sir before we finish the meeting today.
Yeah, I think I would totally agree with what Dr. Pramod has said. He has wonderfully summed up everything and the literature. And I feel that all the experts are winners, as he said, because they were more or less on a consensus, right, when it came to the important points. But they had to debate what was given to them on certain issues. So we had talked about the first debate, and we had summarized that. And like in the first debate also, where most of the speakers had consensus on issues as we discussed, in the second debate also, I think there is more or less a consensus where everybody agrees that not all cases of lumbar canal stenosis or listhesis need fusion. And there are specific indications for fusion. The debate was a multi-level lumbar spine listhesis or stenosis, posterior only versus OLIF fusion. Now, so this is where a fusion is required. What works better? Posterior means a transforaminal lumbar interbody fusion or a posterior interbody fusion, or an OLIF or an anterior fusion. So that was the question. See, as per experience, where there is a single or double level fusion only required, a posterior is standardized and can have good results, though Dr. Amit Jhala very well pointed out to the advantages of an anterior fusion only, or anterior fusion and OLIF also. But we have to discuss multi-level fusions where they are required. I think Pramod also brought out, and that the speakers also said, there are advantages of OLIF, including less blood loss, right, less tissue damage, and the posterior fusions with multi-level would result in more blood loss, more tissue dissection, etc. So I feel that every young surgeon should master the newer techniques, because the horizons for these techniques will broaden, will increase with time. And as Dr. Amit Jhala said, OLIF is no longer a new technique. This is something which has been in vogue for such a long time, and all young surgeons should be familiar with it. Now, I agree that there's a long learning curve, but there's a learning curve to spine surgery as well. And this learning curve should not be overcome in human beings, live human beings, right? There are plenty of ways that you can overcome the learning curve through cadaveric dissection, workshops, etc., which are opportunities. So, there is a role for each technique, and I believe OLIF has its advantages. I am not a young Turk, right? I have not been using it as often, but I would totally advocate all youngsters and even everybody. I would also want to master the technique because there are advantages. And in India, degenerative scoliosis, long level multi-level fusions, people are not as much open to it, but they were not open to total knee replacements at one point of time, and see how it has now. Every family has people going in for total knee replacement. So similarly, in India, degenerative scoliosis, people will go in for it, and where you need multi-level fusions, and in an era where we talk about sagittal and coronal balance, OLIF has definite advantages, and I think we should all try to master this technique. Though I would say that for those who have not mastered the technique, please do what works best in your hands, or refer it to a person who is best at it, right? So if you feel that the person will benefit with an OLIF, why shirk away from referring him to Amit or any of the people who do OLIF well? But if the patient wants to stick to you, do what works best in your hands rather than trying to do something which you are not familiar with, and master the technique not in human beings. There are a number of ways that it can be done. I think those are what I feel. I opened my heart out, and I would compliment all speakers for a very interesting session, bringing out very important facets. And of course, Abhay, who makes any discussion so lively and interesting. Shailesh for moderating it so well. And I think Dr. Pramod Bhilare for summing everything up so well. So it has been a very, very interesting learning session for me. I hope it has been so for all of you. Thank you to the organizers for organizing such a wonderful debate and a wonderful session.
Thank you, Dr. Chhabra. It leaves me to thank you for taking out time, because your 2.5 hours is the most precious 2.5 hours to us. The depth of your knowledge is, always the right guidance for everyone. I thank all the speakers, especially, Dr. Amit Jhala, Dr. Vikas Tandon, who came from the outside and gave such good, information about procedures that are quite specific. Of course, Dr. Arvind Bhave, our own vertebroplasty expert, Dr. Vishal Kundani, and of course the mountain man who was, quite angry today. Dr. Gautam Jhaveri was really cracking a whip, but it was great to create that debate and create the ripples. Pramod summed up everything beautifully. Dr. Bhilare is a star to look forward to. The Pune Orthopaedic Society and the Pune Spine Society and the Sancheti Hospital for lending us, such a wonderful session. And of course, OrthoTV and Neeraj Bijlani and everyone in the back, in the scenes who gave us a platform. And then, the Spineconnect season 2 is the baby of the Virat Kohli of Indian spine. And that's Dr. Shailesh Hadgaonkar. Thank you so much, Shailesh, for bringing this to us. If it's not for you, we would not have such a fruitful Saturday evening. So with that, I think we can call it a day and look forward to the next invitation for Spineconnect. Thank you so much for being with us. And this has been a wonderful Saturday evening. Cheers to everybody.
Thank you so much.
Thank you all.